the chiasm tract or retrochiasmal pathways all the way back. Okay, so if you just look at this, it's difficult to make out. You see some zigzag kind of a pattern on the field, affecting mostly the outer half of the left field. The important thing is, if I show you the right field now, you can see one thing. The left half of both fields is affected. It's not involving the entire field, and it is exactly the same pattern. If you can just look at the cookie cutter kind of a shape on the top, it's exactly the same. You can see that shape. Okay. So what is this? This is a incomplete because it's not the entire field. It's an exquisitely congruous, perfect. You can copy the defect on one side and put it on the other side. It'll be matching. And so on the left side, so this is a homonymous semianopia due to a right PCA territory infarct, due to a left PCA territory infarct. So the message here is always perform the visual fields of both eyes. Okay, that's important. So the next one is this. Would anyone like to tell me what field defect this is? Okay, so it looks as if it's affecting the inner halves of the fields in both eyes. You may think this is a binasal defect, but actually we'll be reading it a little wrong. So this is how it should be read. Okay, so now that you can see clearly, it is a bitemporal field defect. So what's the message here? Okay, the message here is that view the fields as if you are the patient. So place the patient's right field in front of your right eye, the left field in front of your left eye, and then you won't make a mistake as to which side, etc., is being involved. So this is obviously a pituitary adenoma with suprasellar extension. Okay. Important thing in neurology, neuro-ophthalmology is color defects on a hemifield are as significant as the field defect itself. So in a bitemporal hemianopia, they may not be completely hemianopic, but they will have a red desaturation. Red is a very sensitive color to optic nerve disease. So it gets dulled out very easily in optic nerve disease. So here's a patient, the inner halves of the field, the red cap bottle is seen very bright, whereas the red is looking desaturated on the outer halves of each field. So this is a hemidyschromatopsia bitemporally. I told you about field testing confrontation. This is something that you can only pick up on confrontation fields, really. So take a look at this video. So this is a gentleman who says he can see only from the midline to his right side. So he has a left homonymous hemianopia. Okay. So what the doctor is going to do, he's going to do a confrontation field by checking on the right side and the left side and see what he can count. So he's able to count one this side. On the left side, he's not able to see anything. So this is a left homonymous hemianopia. But what is important is the doctor now moves his left hand into the seeing area until he's able to see it in the right hemifield. So both the targets are the right hemifield. But when he shows both together, the patient only sees the right finger and not the left. Separately, he's able to see. So this is visual inattention, very typically seen in a left-sided parietal defect. Okay, right-sided parietal defect. Sorry, left homonymous hemianopia. So this is very, very classic. It's only seen on simultaneous presentation on confrontation targets. It's not something you get on automated perimetry. Moving to my last thing, which is disc evaluation. I think many of you are familiar with the direct ophthalmoscope. As ophthalmologists, we also use the indirect ophthalmoscope. And the best way to see the disc magnified and binocularly with stereoptics 3D is a slit lamp examination with a 90 diopter lens, as you can see in the last picture there. Okay. So what do we see on the disc? A disc can either look simple, it can look normal, it can look pale, or it can look swollen. Okay. If it's pale, we call it optic atrophy. If it's swollen, we have to decide whether it's a true swelling or a pseudo swelling. Okay. So let's take a look at some of the features of a normal disc. So we look at the margin. So the margin of the disc is what the term we use to describe this is a well-defined margin. It's not sharp, it's not blurred, it's just easily seen. Okay. The central area, of course, is the cup where the nerve fibers are not there. The nerve fibers are here on the side, which is the retinal nerve fiber layer. We always look at the color of the disc. This is the right disc, and on your left side, is the temporal side, and you can see the color of the neuroretinal rim is like little paler, lighter in color than the nasal side. That's normal, okay? And of course, we always look at the peripapillary vessels. Why do we do this? We'll come to that shortly. So as far as pallor is concerned, here you can very clearly see the color difference. This is a patient with optic atrophy. Sometimes the entire disc is not pale, only the temporal half is pale. This is called temporal pallor. And the classic field defects you get here are a central or a centrocecal scotoma. Here is an altitudinal defect, upper half, lower half. This is seen in ischemic optic neuropathy. This is a bow tie defect, not only just the outer half, but the inner half also. And here you get a bitemporal hemianopia. This is very classic in a chiasmal lesion. This, of course, is a classic post-papilledema optic atrophy. The disc is blurred, a lot of peripapillary changes, sheathing of the vessels that you can see there on the peripapillary area. This disc looks swollen, but every single blood vessel on this disc is visible. Okay. Here in this corner, you can actually see a little lump on the disc. This is optic disc drusen, calcium deposits on the disc. This is pseudopapilledema. This is not a real swelling. Okay. And you can very easily pick it up on an ultrasound, where you can get a high spike due to the calcium, or if you did a CT scan, you'll see that little spot there. Okay. This is a very dysmorphic disc. Again, looks swollen, but it's actually a disc which is sort of tilted to one side. The insertion is tilted, so you get this kind of nasal side looks swollen, the temporal side. Lot of peripapillary degenerative changes there. So these are dysmorphic disc, congenital discs as well. Okay. Swelling, couple of things to note here. This is a true disc swelling. Why do we say this is true? Just look at the blood vessels here. They are obscured by the retinal nerve fibrillae edema. So obscuration of the vessels on the surface and just outside the disc is important. The other thing you can see here is these folds on the retina concentric to the disc. These are called Peyton's lines, only seen in true disc swelling. Okay. Couple of other reasons for swelling is papillitis, neuroretinitis, where not only the disc is swollen, but the posterior retina is also swollen. You can see a macular star-like figure there. That's neuroretinitis. The ischemic optic neuropathy, where you get an altitudinal kind of a pattern. The inferior half of the disc is swollen. The superior half is a little pale in non-arthritic. The more dangerous variety is below, an arthritic AIO due to temporal arthritis, where the disc is totally infarcted, and there's also, in this case, a serial retinal artery occlusion as well. Okay. So some takeaways, my last slide. As far as vision is concerned, visual blur can be there. Always check if it's monocular or binocular, because with each eye separately, if the patient is seeing clearly, and with both eyes open, he's complaining of a slight blur, you're dealing with an efferent system oculomotor issue. Okay, slight diplopia, where the vision, the images are not totally separate as yet, they're slightly out of focus that way. Each eye, of course, always test it separately. You can do all three together with one eye patched. We also check brightness and contrast sensitivity. We're not spoken about the pupil, but just use a good torch when you're checking the pupil. You have an RAPD if there is asymmetry of optic nerve function. And please remember the last one, difference in pupil size is not a symptom of optic nerve disease. It is a symptom of a third nerve palsy or something else, but not an optic nerve disease. Fields, always do it with both eyes and interpret it correctly. I've spoken about the importance of confrontation field defect. As far as pallor is concerned, please do not evaluate it by photographs someone may send you. Those photos may be overexposed or underexposed and give you a wrong impression. So always look at the patient's fundus directly. Disc swelling or papilledema, sometimes you see it, patients are diagnosed as papilledema only on the MRI. It is something that is seen on the fundus and not diagnosed primarily on an MRI. And last but not the least, bilateral disc edema, before you jump and do MRIs and all that, just check the patient's BP. They may be having a malignant hypertension as well. So never forget the importance of history in your ophthalmology as well. Thank you very much for your attention.
Thank you, Dr. Naveen Jayakumar, sir. It was a very elaborative talk on evaluation of neuro-ophthalmology per se. And again, I would like to stress here, confrontation again is a real bedside evaluation of knowing the defective fields in patient. And it can be done anywhere, if you don't have Humphrey's analysis.
Yes.
Thank you, sir.
Thank you. Thank you.
Thank you, sir, for that wonderful talk. The second talk, which was supposed to be on extraocular eye movements, Dr. Sudhir Kothari is not able to be present here today because he is unwell. So we move on to the third talk, clinical evaluation of higher visual pathways by Professor Madhusudanan. So for neurologists, Professor Madhusudanan doesn't need any introduction, but for all the others, he is one of the most acclaimed clinical neurologists, and he has trained many generations of neurological students. He was a professor and HOD of neurology at Travancore. He is at present the professor and HOD of neurology at Travancore Medicity Medical College and Hospital, Kollam. He is adjunct professor of neurology at Manipal University, and he is a senior consultant neurologist, PRS Hospital, Trivandrum, and Professor Emeritus Medical College, Trivandrum, formerly Professor and HOD of Medical College, Kottayam. He has 46 publications in national and international journals and contributed numerous chapters in textbooks of neurology and medicine. And he has published books on higher neural functions. He has won numerous awards. The list is quite long and elaborate. I won't take time, and I would rather yield the floor to Professor Madhusudanan to give his talk on clinical evaluation of higher visual pathways.
Good morning to everyone. Am I audible to you? Yeah. At the outset, I would like to thank the organizers, especially Dr. Vasudevan, for inviting me to be part of this program. What I am going to talk today is the higher cortical visual disorders. Now, to understand higher visual disorders, you must know what the steps are involved in the perception to action. What do you mean by perception to action is that when you see an object, particular stimulus, you recognize it and respond to it. There are many steps involved in this particular sequence of action. What are the steps involved? First, you have to identify and recognize the stimulus, that is gnosis. Secondly, you have to attend to the stimulus. That depends upon the significance of this. Every stimulus, you don't attend to it and respond to it. That is by your attentional system. Third, you must know where the stimulus is located. That is the where system. Is it from your own body? For that, you must know your body schema. Or is it from outside the body? For that, you must know the spatial location of the stimulus. That's the spatial orientation. Fourth, to act on the stimulus, the spatial coordinate of the object in this space has to be related to your body coordinate for your limb and eye position to give command to your eye or your limb to reach the target. That is the sensory motor integration. If the integration is defective, your hand or eye will not reach the exact position of the stimulus or object, resulting, for example, optic attacks. I will be showing examples later on. Fifth, you must have an intention to do the motor act. Okay, you found everything, but you should have intention to do that. That's the internal system. Sixth, you must know how to do the motor act. That is by your praxis. So all these steps are involved for you to respond or act to a stimulus which you see. Now, the disorders can be in each step. For example, if you have a problem in recognition, it's called agnosia. Attentional system neglect. Spatial oriented stimulus is defective in the body schema and the spatial orientation. It can cause autotopagnosia, hemispatial neglect, visual disorientation. Problem with linking the spatial coordinate to the limb and coordinates, it can present limb and optic ataxia. How to do the motor act is disorder causing apraxia. Internal system is the akinesia. So in each step there can be disorder. I will be confining mainly to your higher cortical functions. Now, when you see an object, the visual pathway helps to form an image of the object in the retina. But it is not enough. We must know what the object it is, what is its color. We must also know where it is located in space, how far it is from you, what is the depth, is the object moving or not. All this information we must know. For these, there are higher areas in the visual cortex. which are responsible for each of these functions. The occipitotemporal areas are specialized for identifying specific objects, faces, visual scenes, and for reading. And that is carried by what is called the ventral stream, which goes from the occipital cortex towards the temporal lobe. The occipitoparietal areas selectively process for visual spatial function, location of the object, its motion, how to reach the object. Those is done by what is called the dorsal stream, which is actually occipitoparietal pathway. In simple terms, ventral stream is the what system. The dorsal stream is the where system. What system means it recognizes the object what it is. Where means where it is located. And also the dorsal stream also it's also otherwise it's also got another function, how system. That means using your visual information to guide your limb movement. Now, in summary, what are the functions of ventral system? Object recognition, color recognition, face recognition, and reading, all of which I'll be talking to you in detail later on. Let us see what is gnosis. Gnosis is, in a simple English term, is recognition, to know. The agnosia refers to a condition in which there is normal perception of the external stimuli, but one is unable to associate that stimuli with the prior knowledge of that meaning or significance. It's not that just see it and understand, you have to also have the meaning to the stimulus. That is done by the what is meant by gnosis. The best, a beautiful definition of an agnosia is that agnosia is percept stripped of its meaning. You are perceiving it perfectly, but it has no meaning. That is what is called the agnosia. It can be through various sensory modalities. For example, if you see a bunch of keys or see a written word like key, through the visual modality, it has to reach the semantic store, your memory bank where that information is stored. If you see a heard word key or see the sound of a jingling of the keys, that through the auditory modality reach the semantic store. If you touch something to recognize that, the somatosensory modality gives information semantic store. Ultimately, the gnosis, recognition, is taking place in the semantic store. And from there, it goes to the lexicon for giving name to the object. That is for the naming. In fact, what agnosia refers to is the defective input from these various sensory modalities, which is not reaching your sensory store. That is agnosia. So agnosia in simple terms is a modality-specific recognition impairment is agnosia. So it can be visual agnosia, it can be auditory agnosia, it can be somatosensory agnosia. The semantic story itself is lost. You don't call it as agnosia. It's actually it cannot be called as agnosia. It is a semantic memory loss. It looks like agnosia, but it's actually to that sector of memory is lost from your brain. The input to the lexicon is lost. You can recognize everything, but you cannot name the object. So these are the steps involved in the recognition and naming of an object. Putting in other words, initially there is elementary perception. Then there's an upperception. What is my upperception? It's nothing but a complex perception, where you synthesize the various stimulus features into a meaningful whole. That is called the upperception. And these steps complete the perception level. That information has to be matched with the stimulus in your brain. That is, the output of the perceptual processing is matched with a representation of the same object stored in your visual memory. And that is matching of the stimulus. That is step one in visual recognition. Once it has matched, okay, you reach the memory bank. This similar object is there in the memory bank. That gives the meaning to the stimulus. That is the ultimate recognition. That is by the semantic conceptual field. That is the recognition of the object. Once you recognize the object, it has to go to the language area or the phonological lexicon to give the name to the object. Now come to the visual agnosia, visual object agnosia. That is, as told before, it is inability to recognize previously familiar objects through visual modality. There are two types, apperceptive agnosia and associative agnosia. What is apperceptive means? It's not a true agnosia. It's a problem of apperception. That is a problem of perception. So you cannot be called as agnosia. But unfortunately, this time has come into this realm. So they are unable to integrate the visual information into a detailed structural description of the stimulus. They may grab on the fragments of the picture and try to make inferences from text and color. So what is a site of lesion for a perceptive agnosia? It has to be bilateral. So it's a bilateral and a parieto-occipital lesion. Occipitotemporal cortex is responsible for the apperceptive agnosia. Now, how agnosia? This patient, just ask him to copy the digits, copies the diagrams or figures. They're unable to copy because the letter word A, they cannot understand the peristimulus speech of that. They cannot synthesize stimulus speeches. They're unable to copy or draw. If you ask the patient to match a diagram or a symbol like this with a similar looking diagram, they're unable to match from the array of the similar pictures. These are tests for perceptive agnosia. Let us see what is this problem in this patient. A patient cannot recognize this bucket from view from above, but can recognize this. What do you call this problem? His recognition is there, you can recognize, but not through the unconventional views. That is what's called the perceptual categorization deficit. It's again another form of perceptive agnosia. They're unable to recognize objects when shown from unusual views. Lastly, the main agnosia is the associative agnosia. They have intact perception but unable to identify the object. For example, a doctor may identify the stethoscope as a long cord with round thing. Everything will describe about the object, but it does not know it's a stethoscope. That is associative agnosia. But however, they are able to copy and match perfectly well. Now, this is, let us say, this problem. A patient, if he's shown a spectacle like this, he could not recognize a spectacle. But he can recognize the spectacle when he is put on the face. That means a mild agnostic degree of agnosia can be detected by placing the object in the correct context. This is also visual agnosia, but a milder form. Now, what are the types of associative agnosia? Divided into two types: semantic access agnosia and semantic agnosia. Semantic access agnosia is the true agnosia in which the memories are still intact, but that simply cannot be reached. Your visual perception is normal, cannot be reached in the memory bank. There's a block in between that thing. On the other hand, semantic agnosia, where the stored memories and knowledge objects are being destroyed, erased. It's actually kind of a dementia-like thing. That's not there in your brain. It is not a true agnosia. It's a category-specific visual memory loss. They have intact verbal memory. Now, the question comes, suppose a patient is not able to recognize an object, tell you what it is. Is it due to the fact that your visual perception is normal, not reaching the memory bank, or memory bank itself is lost? How to differentiate that thing? You have to test for visual imagery. In the case of visual agnosia, that part is there in the brain. So the visual imagery is lost in semantic dementia, but not in visual agnosia. Because agnosia is a percept without meaning. The perception cannot reach the memory bank, but not the loss of memory bank. Whereas a memory bank loss is what is said semantic agnosia, not the associative agnosia. What is the site of lesion for the visual imagery is the left temporo-occipital region. Then coming to another type of agnosia, which is called the integrative agnosia. Sometimes you may come across certain patients where you does not either fit in with the perceptive agnosia nor with an associative agnosia. Here, the patient can perceive elementary shapes, but do not integrate the parts into a perceptual whole. They match symbol shapes slowly and produce laborious and slavishly correct copies of the drawing in a part fashion, but fail to appreciate how the parts go together. I'll give some examples. Say, for example, they failure to segregate figures from the ground effectively. For example, patient may be unable to detect symbol shape against a pattern background. You all know what is in the background behind. You know the picture of the elephant, cat, and the dove. But if you are projecting in this fashion against a pattern background, this patient cannot recognize it. The other example is that there are also more embedded in identifying items that overlap with one another compared to the same items present in isolation. That is interpreting overlapping figures and letters. So suppose you show these letters like this, TJM, they can read correctly TJM. But when you overlap like this, they are unable to read these three letters. Similarly, if you get overlapping objects like this, you can easily find out what objects are there, but this patient cannot recognize with them. They also got impairment in various other faculties, like for example, object recognition by line diagrams. They cannot say what the object it is. They may say that the right one is a lamb, not a mushroom. Similarly, inability to identify object by silhouettes alone, this again become problem for them. Real image they can recognize. And failure to interpret broken pictures and letters. You all know what the object it is. But these patients with integrative agnosia will not be able to say it is a picture of the dog. Now coming to the neuropathology of the visual agnosia, the lesion causing visual agnosia is in the ward system. They are in the posterior inferior part, affecting the ventral and temporal occipital areas. On the other hand, semantic agnosia means the memory bank, that is anterior inferior temporal lobes are affected. That is the site of conceptual semantics. And the lesion has to be bilateral in the case of a semantic agnosia. Now coming to how many minutes do you have? I can take 10 more minutes. 15 minutes, 10 more. Now, optic aphasia is a defective naming confined to the visual modality, but can name by other modalities. They can preserve the ability to recognize the object. Only problem, they recognize everything but cannot name. So there could be a problem in such patients. Imagine that red area is the infarct. It's got right homonymous myopia. Left side visual field is only seen. That information reaches the right occipital cortex. That has to go to the language area through the splenium. The splenium is also cut off, means what? They can see it, recognize it, but cannot name it. That is what is called the optic aphasia. So in summary, apperceptive agnosia is unable to identify objects, unable to match or copy. Perceptual categorization deficit, unable to identify objects when presented in unusual way. Associative agnosia are unable to identify but able to match and copy. Optic aphasia recognized normally but unable to name. Semantic categorization deficit is a type of dementia where there is a loss of category-specific visual memory. Look at this particular patient's problem. He is able to volume. He's able to write normally, but he asked to read, he cannot read. He's fumbling even with the first letter. What would be the problem here? He's able to write normally, but not able to read. That is alexia without agraphia. The site of lesion is exactly same as the previous for optic aphasia. Here the problem is happening is where it is the lesion in the visual word form area. That is the area V3, V4 area. There where your word engrams or word dictionary is stored, semantic modes are stored. If that sector is lost, you can only read by letter. You cannot retrieve it quickly. So let us see, for example, this particular patient is asked to read the words. See how is he reading? Chair.
T.
He's picking up letter by letter and coming to the letter. That is called the surface alexia, where he cannot read as a whole word. That sector, the visual word form area is lost. So you can take in another route, the phonological route, where he can sound out each letter in his brain and then coming out with a word. Now, this is prosopagnosia, where the patient is unable to recognize familiar persons. So he's not able, he can see, he's describing everything perfectly well, but who he is not tell. Remember that to call prosopagnosia, he should have intact knowledge of the persons. One should have a normal semantic memory of the person. It is not that, what I am asking here is that I am asking him, is the picture of Mahatma Gandhi? He said he cannot say. I don't know, is Mahatma Gandhi or not? He's a bald person. Then I asked him who Mahatma Gandhi is. He said correctly. Then only you can call prosopagnosia. If he cannot say who Mahatma Gandhi is, then his memory sector is lost. That's not prosopagnosia. So they can recognize face as a face, can discriminate faces according to sex and race. They can decode emotional expression. I think the site of lesion is the fusiform gyrus. The activation is usually bilateral. However, it is more commonly observed in non-dominant hemisphere. They can also have impaired recognition of emotions with all the thing that site of lesion is in the right inferior parietal cortex and in the right intracranial cortex. Now coming to color perception, That can be cerebral achromatopsia, the color lost due to a lesion in the cortex. That is, the lesion is usually in the inferior calcaneal, anterior to the inferior calcaneal cortex. That is the lingual and fusiform gyri. If it is used to produce complete cerebral achromatopsia, lesion has to be bilateral. If it is unilateral, you can have a contralateral hemiachromatopsia. Usually, as told before, lesion has to be bilateral, and if it is bilateral, usually associated with superior cotton denopia, if the lesion happens to extend a little more backward into your visual cortex. If it's a unilateral occipitotemporal cortex, in fact, you may find that hemiachromatopsia affecting only the contralateral hemifield. The lesion extends posterior to the V4, the infracalcaneal cortex is also affected, so you can have a contralateral upper cotton denopia also. Now, the other abnormality is what is called the color agnosia, the inability to access the semantic store. It is a color categorization problem. Does not know, you can recognize the color it's at all, but it does not know what is the color for, what is it used for, what is the object it is used for. Does not know which color to be used for a particular object. They can match the colors, but cannot choose the correct color to paint a picture, for example, yellow for banana, green for grass, etc. And color anomia is nothing, everything is intact, only problem is naming problem. So that's similar to optic aphasia. Color amnesia is a more profound disorder. It is a dementia portion. The color sector is lost itself, unable to retrieve from the semantic memory the typical color of the object. That is a degradation of a sector of semantic memory dedicated to storing object color associations. Let us see this example. See, this person is asked to name the color. Then he is telling he cannot say what it is. It may be blue, it may be green, like that he's telling. So he cannot recognize the color. So he could not name. The possibilities can be anything. Then the next step is to match the color, whether he is able to match the color or not. And ask him to match, then he said he matched the color. That means it's not achromatopsia. Right. Then it has no color blindness. The next step is what you do is I'm given a picture of apple and ask him to choose a color to color the apple. You should have chosen the green, but instead what is he choosing? He choosing the yellow color. That means he does not know which color to be given for the particular object. That is a color agnosia. There are two possibilities. Either it's a color agnosia or that color is lost in his brain. It's called color amnesia. But it's not a color anomia. Color anomia means the only problem is naming. You could color the object clearly well. So what test will do differentiate? Now what is it now asking him? What is the color of the green grass? He said green. What is the color of the sky? He said certainly blue. That means that sector memory is there in his brain normally. Only thing that the use of the color is lost. So what is he having? Color agnosia. On the other hand, this particular patient asked him what is the color of the apple. He said blue. That means even from the memory, the color concept is lost. Now, in another 5 to 10 minutes, I'll talk about dorsal stim disorders. Once the object is recognized, the next step is to find out where it is situated. This is mediated by the VER system, that is a dorsal stream. The disorders can be deficit in visual attention, deficit in spatial representation, that is inability to judge the location, distance, and orientation. Disturbance in visually guided eye movement, that is oculomotor apraxia. Defective visually guided hand control, your hand cannot reach the seen target. Defective motion and perception. Let us see this particular patient's problem. If a doctor is standing on the right side and the patient is asked to touch the ear of the doctor. What is he doing? He is searching the ear on the cheek. His attention is only localized to a small area in the cheek. It's related to that area. He is not taking his attention somewhere else. That is a spotlight attention. That is restriction to spotlight attention. If the persons are shown letters written in big letters like this, CAT, he will only read A because that is only coming under the purview of his visual attention. If the letters are in small letters, all things will come under the purview of the visual attention. He can read that thing. Simultagnosia is a condition in which patients are unable to simultaneously appreciate the multiple objects or multiple elements of an object in the same visual image, unable to appreciate the meaning of the whole, so-called piecemeal perception. I think the symptoms, I think I'll skip all those things. If they shown a number like 10, 0, 8, 9, they're about only saying 8. The classical picture, all of you know. Now, there are mainly two types, dorsal type and the ventral type. Dorsal type is already shown you problem with attention. That is, his attention is shrink to small area, so he cannot perceive all the elements of the picture. The ventral type is due to the ventral stim disorder, due to slowed visual processing speed, that failure to simultaneous recognition of individual parts of a multi-part object. If you show a letter H written like with small t's, these people will only report T, not the H. That is a dorsal type, where the attention is riveted only to small area in the visual field. There can be other pathophysiological mechanisms like sticky fixation, disconnection syndrome, defective eye movement. Even simultagnosia can also occur due to frontal lesion, because to form a concept, if you suppose multiple things are in the picture, you have to form a hypothesis what that picture means. That occurs your executive function, frontal function. So that can also produce simultagnosia. Now, what do you see in the next video? So look at this patient's eyes. The doctor is showing the finger in front, but look at the eye. He's asked to touch the finger. His eyes are stuck there only. He's not able to deviate the eye from that to the object. See? See, he's taking the hand there only. That is called the sticky fixation or spasm fixation. Spasm fixation consists of impaired initiation of saccades in the presence of fixation of target, but normal initiation in the absence of saccade. Normally, he can move everything normally. If you show an object, his eyes are stuck to that object. He cannot deviate from that. That is called the sticky fixation or the spasm fixation. Then you may ask, why can't it be oculomotor apraxia? For example, this patient is a sticky. He can move the eyes normally on both sides. That means it's not an oculomotor apraxia. See, the story of a 60-year-old lady, she noticed some visual problem in that she could not put latch correctly in the door. She put it in the wrong direction. So when asked to draw a clock diagram and put the numbers in the clock, see where she is taking the pen beyond the the circle, and taking somewhere else and putting 3 there. So what is the problem with this patient? Is she seeing it, but there is some problem. What is the problem? Let us see, this is another patient, same disability and abnormality. He can see the torch and ask him to touch the torch. He is taking his hand somewhere else. He is seeing the torch somewhere else, not in the correct place, and taking the hand to the other direction. And what is this problem? This is called the visual disorientation. That is inability to localize the spatial position and distance to the object despite visual acuity. So people will come to the ophthalmologist saying that he is blind because he bumped into the object. We may bump into the wall. But the problem is you cannot get the distance between the two objects and distance between how the patient is away from the wall. So they bump into the object. The spatial impairment is restricted only to the visual modalities. These patients are able to localize the auditory stimuli correctly. If you hear the torch sound, he will treat the torch correctly. But showing a visual object, he will be groping somewhere else. This is defective local. I think I'll skip in the interest of time. The lesion is bilateral parieto-occipital lesions near the angular gyri. Unilateral lesions can produce contralateral visual disorientation. So, bedside test, ask him to touch where it's about a circle point, dot in the center of a circle. Ask him to touch the circle. You can touch he will not be able to reach the dot because he does not know where the dot is situated. Let us this particular video. The lady is asked to touch the finger of the doctor with the left hand. Touch it correctly. Touch the nose correctly. Again correctly. But look at the right hand. When it is reaching towards the target, but it is attaching towards the target, it becomes coordination towards the target. It does not reach the target correctly. What is it? But towards the nose is reaching it correctly. Touch the nose correctly, but on the same target, it becomes ataxia. What is the problem? That visual input cannot guide the eye movement correctly to the target. That's a problem with what's called the optic ataxia. misreaching of visualized target, but can touch the body part correctly. So if sound is there, they can reach the target correctly. Only seen target, they cannot reach the target. So miss the object they reach for, but appears to grow up around the object. They had clear sight. I think this, what is a pathophysiology is a visual motor disintegration. Now there's one particular area in the brain called the parietal reach region of the area V6A or middle interparietal sulcus. This area input from there, output will go to the dorsal premotor area for reaching the correct position of the motor movement of the seen target. There is also another area called area 5D that is for the online control. When you're moving in between the object is moving, you have to correct it. That for the online control is done by the area 5D. The site of lesion is the input output from the parietal reach region, the dorsal premotor area, causing the optic ataxia. I think to understand this also, you have to remember that to see a target on the right side of the visual field, it is the left visual association is activated. Same the opposite side. So this left visual association area is concerned with directing motor movement of both hands to the same target on the right side. So it goes to the left motor area to reach the object on the right side with your right hand. Then if you want to reach a target with the left hand, the input has to go to the right motor cortex. That will reach the target correctly with your left hand. So lesion causing the corpus callosum, you can have what is called a crossed optic ataxia. You cannot reach the hand on the left side of the right hand, but can reach with the right hand. I think also, again, depending about the site, you can have a bimanual optic ataxia. Here you can have optic ataxia the right hand. Here it will be on the left hand. Here it will be on the both sides. Now, this video of you all must have seen, this is a case of oculomotor apraxia. This is a little different from the classical oculomotor apraxia. This is called psychic paralysis of gaze. That is difficulty in initiating voluntary saccade to visual target despite unrestricted eye movement. They could direct their eyes accurately to location the sound or region and verbally direct to the doctor, but not to target that is present visually. This is not due to saccadic palsy, and this is information from the Watt pathway goes to the lateral interparietal area. From that substance, the visually mediated saccade go to the frontal eye field to produce a saccadic abnormality. There is a site. Lastly, I'll end my talk with topographical disorientation, loss of ability to understand the layout of the environment. It's a form of place blindness, impaired recognition of the previously familiar landmarks and emotional environmental scenes. They manifest with problems in navigation. They get lost in surroundings. The area concerned is the parahippocampal place area. This normally recruits hippocampus and retrospinal cortex for the formation of the mental map of the environment and directional orientation. So it receives hippocampus information, which produce the map of the environment, and retrospinal cortex, which produce the orientation of the directional orientation. So it can include two disorders, landmark agnosia and directional disorientation. In landmark agnosia, difficulty in recognizing landmarks such as buildings. This is seen lesions to the right parahippocampal place area that is located in the choroidal sulcus. Or it could be a directional disorientation, difficulty with sense of direction despite recognition landmarks. Then the lastly, depth perception. Depth is computed with binocular visual information. As you know, because a consequence separation of the image in the eye, the brain, that's mild disparity in the visual image is computed in the brain to form a three-dimensional perception. The area 18 is responsible for that. What is symptomatology? A flight of stairs may appear as number of straight lines on the floor. They are flat on the floor. They cannot assess a step. Patient may reach an object and miss it. Driving and spotting will be tremendously difficult. You cannot assess the depth of an oncoming and the distance of the oncoming vehicle. And when you look at actually what is the physiology behind it, when you look at a moving object, retina may generate image multiple times a second. This is how the retina generates the image. It is the cortex which perceives it as a smooth, continuous movement rather than seeing individual frames. So in a person with a defective perception, they will see like this, not like a continuous motion. So for example, patient is putting a water and a cup, a tea into a cup. The patient is unable, they are unable to see the rising level of the fluid in the cup. So what will happen? when attempt to fill a cup, patient may note that fluid appears to be frozen like a glacier and does not know when to stop pouring because she cannot appreciate the change in the fluid level in the cup and it is too late. So the pathology is the empty area, the area, V1 area, causing the defective motion perception. It can also be unilateral hemiacropnopsia, where one lesion can produce a defective motion perception of the other side. So I think if that I will stop because, sorry, I exceeded little time. Thank you for your patient listening.
Thank you very much, sir, for that very illustrative talk on a very difficult subject, which was made very easy. Any comments or questions? Thank you, sir. I think we move on to the next session.
I thank you, the chairpersons. Now we are starting the Symposium 2. I welcome Dr. Mukundan, Dr. Ranganathan Jyoti, Dr. Prabhu Radhan, and Dr. Naveen Jayakumar.
I'd like to first invite Dr. Nirmala Devi from the Department of Neuro Ophthalmology at Aravind Eye Care System, Chennai, to give her talk on an approach to disc swelling or disc edema.
A very good morning to one and all of you. At the outset, I would like to thank Dr. Rupesh sir and the organizing team to give me this opportunity. So without delaying further, I would like to start on my topic on approach to disc edema. So as you know, that optic disc edema is swelling of the intraocular portion of the optic nerve. Now, this can be of various etiology. It can be ischemic, or it can be infiltrative, or any inflammation, vascular cause, and many other cause. Throughout on my topic, I'll be coming across few case scenarios also on basis of this. So it's basically the compression of the fibers in the lamina cribrosa that leads to tissue edema and increase in the intracellular matrix pressure. So basically here the optic disc edema arises from blockage of the retrograde and anterograde exoplasmic transport in the optic nerve. Whereas in papilledema, the basic is the raised ICT that is causing the exoplasmic stasis, resulting in disc edema. So before going further, it is very important to know the Frison's classification of grading of disc edema. So as you can see here, the first picture, the grade 1, I will be pointing on there. So initially in the grade 1, you find there is a C-shaped halo that is surrounding the disc and sparing of the vessels and the temporal part of the disc. Temporal part of the disc will be clear, and you get those radiation nerve pipe striation disruption. Whereas in grade 2, this halo will become more circumferential. Okay, and there is no major vessel obscuration. Whereas in the third stage is where you find the this is the obscuration of the vessel leaving the disc, okay, which is very classical of the grade 3. And the grade 4 is where you find there is obscuration of all these major vessels and a complete elevation of the cup, and includes the cup also. So this is the cup. I'm sorry, the pointer is very sensitive. And the grade 5, okay. So the grade 5 is so the grade 5 is where you find, see, there is complete obscuration of the vessel, and you find of the vessel leaving the optic disc, and you will find all features of grade 4 is there in the grade 5. So as I said before, the etiology can be inflammatory or an ischemic or a hereditary cause or a irradiation or any orbital cause, pseudo disc edema, which I will be coming, and then systemic causes. So I would like to discuss few cases here. So my first case is a 38-year-old female who had severe throbbing headache for a week, vomiting and neck pain. Visual acuity was 6.6, pupil was normal, visual field showed blind spot enlargement, BP was normal. As you can see here, there is disc edema. Now we proceeded further and found in the in the CT scan, as you can see, there is an enlarged ventricle, and this is the meningioma. So this is the OCT of the patient showing the RNFL thickening, indicating disc edema. So this is a case of papilledema. Now the next case is a 28-year-old female who had headache, transient visual loss, no history of vomiting or other systemic disorders. Patient was on OCP for 6 months. BP was normal. MRI brain was normal initially. This showed disc edema, as you can see here. On repeating the MRI scan, as you can see on in the arrows, there was a flat sclera and a empty sella turcica, as you can see here. Okay, and this is the flattening of the sclera. So this is a case of a idiopathic intracranial hypertension. Now the next patient is a 26-year-old male who had no specific complaint. Vision was 6.6, color vision normal, field showed enlarged blind spot. So now here, this is, see, you look at the disc, you find those, yellow elevated lesions here. So this is very classical of a optic nerve head drusen. Though on OCT, you will find sometimes, it will not be normal. If there is a compression, it can show thinning of the optic nerve fibers, as you can see here on OCT. So this compression also can cause some field changes. Okay. Like this, as there is a blind spot enlargement. And on proceeding to a B scan, very classical hyperechoic region, which is very classical of your optic nerve head drusen. And fundus fluorescent angiogram, you find there is a fundus autofluorescence, which you can see here. Again, CT scan showing the calcific lesion, as you can see here. Okay, so this is that was a case of optic nerve head drusen. Now coming to pseudo disc edema, see, this is not a true disc edema. Okay, it will appear hyperemic. but there are no other changes. Vision will be normal, fields will be normal. Okay, you will not find any visual loss in this patient. So the conditions are, one is the myelinated nerve fiber, as you can see here, and then a tilted optic disc. See, all this you find that the disc will be looking hyperemic. And the other condition is where you get a crowded disc. Sometimes when you look into the fundus, you will find that the disc will be crowded. These are all not true disc edema. Then the other condition is, which is very common following a cataract surgery, especially a hypomature cataract, you find that the disc is hyperemic. Then you get these choroidal folds. These are conditions where you get a ocular hypotony. Okay. So the next patient is a 48-year-old male who had blurring of vision in both eye, uncontrolled diabetes, vision 6/6, anterior segment was normal, field showed peripheral sectoral field defect, VP normal, CT scan normal. So can you see here? If you clearly see, there is a disc edema, and it's not very clear, but patient had a moderate NPDR. So proceeded to a fundus fluorescent angiograph, which showed leakage from the disc. Now these patients, which we encounter in day-to-day diabetic patients, where they get this diabetic papillopathy. So these diabetic papillopathy patients, you find that fields will be normal, vision will be normal, pupil will not show any relative efferent pupillary defect. The next case is a 54-year-old male who came with defective vision. BP was 210 by 110, and vision was 618. Anterior segment showed sluggish pupil. So very classical disc edema, and then you have this exudates, you have all these hemorrhages. So what is this? It is a hypertensive, grade 4 hypertensive retinopathy. Again, in this, vision will be normal, fields will be normal, pupil will not show any relative efferent pupillary defect. So next is a 30-year-old female who came with decreased vision for a week, burning sensation both lower limb, straining maturation, paraparesis, brisk superficial and deep tendon reflexes, and decreased sensation over the lower limbs. Extensor plantar response, vision, PL, and pupils were dilated. So can you see the disc edema in both the eye? So if you clearly see here, there is a bilateral peduncular hyperintensity, and these are the longitudinal extensive transverse myelitis, which is very classical of a neuromyelitis optica or a DeVick's disease. The next patient is a 60-year-old female who came with headache, 2 months, defective vision, 1 week. She was by mistaken given Dimox for thinking that it was an idiopathic intracranial hypertension, and visual acuity 624 in the right eye, left eye 612, pupil was normal. Now, this was the anterior segment slit lamp examination of the patient showing these carotid precipitates. So, so if you clearly look into the fundus here, you will find, you can just look at the arrow, there are few hypopigmented granulomatous lesions that you can see. These are the hypopigmented lesion. You look around the disc also, you will find few. See? So, and if you clearly look at the macular area, there is a fluid level, okay? And this is a very classical picture of VKH, which we call as a Vogt-Koenig-Harada syndrome. So next is a 25-year-old female who had decreased vision in left eye for a day and had pain behind the eye, worsening on eye movement, visual acuity 6.6 in right eye, left eye 260. Pupil showed a relative efferent pupillary defect in the left eye. Visual fields in the right eye was normal. So can you see here, there is a disc edema. After 2 weeks, you get this macular star formation. So this is a very classical picture of a neuroretinitis. So it's, again, I would like to stress here, by just looking at the disc edema on day one, just don't go by the dictum that it is an optic neuritis. Now, after 2 weeks, if you see, we were all, every time we review the patient after 2 weeks to see if there is any macular lesions are there or not. The next case is a 58-year-old male who had sudden painless vision loss in the right eye, hypertensive on irregular treatment for 6 years. BP was 160/90, visual acuity 560 in the right eye, and left eye 6.9, field. Okay, before the field, I'll show you this. This is the disc edema here. Sometimes you get a classical pallid disc edema. One area will be pallor, sometimes the inferior part, and then you get this disc edema. And sometimes a Peyton's line, as you can see here. Now look at the fields. You get this classical altitudinal field defect. So OCT again shows the RNFL thinning. Okay. So, and fundus fluorescent angiography showing a delayed incoming, or we call it as a patchy filling of the optic disc, as you can see here. Now, this is a very classical presentation of a non-arthritic anterior ischemic optic neuropathy. Next, the second last case is a 58-year-old male, blurring of vision for 15 days, dull pain in the left periocular region, anterior segment was normal. Okay, so can you look here? There is a disc edema here, and you see these lines. These are all the choroidal folds. Okay, so, and then we did a B scan showing this typical T sign. So this is a patient of a posterior scleritis. Next is a 38-year-old male who had defective vision in the left eye, a driver by occupation, anterior segment, the pupil was very sluggish. Okay, so this is a case of CMV retinitis where you get the classical pie ketchup cheese retinitis or a pizza pie appearance, which you can see in a CMV retinitis. So when you have a case of a unilateral disc edema, you have to think whether it is normal or a normal visual acuity or a decreased visual acuity. If it is a normal visual acuity, then you think of these: papilledema, a non-ischemic central retinal vein occlusion, a diabetic papillopathy, or a pseudodisc edema. Now, if the visual acuity is decreased, whether it is a gradual decrease in vision or a sudden decrease in vision. If it is a gradual decrease in vision, you think of thyroid ophthalmopathy, infiltrative cause, or a papilledema, or Foster-Kennedy syndrome. Now, if it is sudden, whether if it is a painful or a painless. Now, if it is painful, then you think of neuritis and a posterior sclerosis. If it is painless, you think of a NAION or a Liebers or a ICRVO. The next thing is if the disc edema is bilateral or unilateral. If it is bilateral and you find again the vision is normal, then you think of a papilledema, a benign ICT, grade 4 hypertensive retinopathy, diabetic papillopathy, and a pseudodisc edema. Whereas if it is unilateral, if the vision is decreased, whether it's sudden, then you think of toxic, anterior ischemic optic neuropathy, papillitis and inflammatory, and if it is gradual, then a vintage papilledema or a thyroid ophthalmopathy or an infiltration. Thank you.
A very good presentation showing all the cases, case-wise, and the last tabular column was very informative. Thank you very much. I call upon the next speaker, Dr. Stephen, on OCT, indications and interpretation. Regarding this OCT, we as neurologists and neurosurgeons, we see the pictures, but we don't know how to interpret it. Probably this lecture is going to be more informative for a neurologist and neurosurgeon, how to interpret this OCT. Because you don't, the OCT, you give the picture, but interpretation and the discussion is not given in the along with the picture. So we are not able to read the OCT.
Good morning. I thank MGM for giving me this opportunity. Yeah, my topic for today is optical coherence tomography in neuro ophthalmology specifically. We are using extensively in ophthalmic diseases, but as a neuro ophthalmologist, yeah, we use extensively in neurological and neuro ophthalmology disease also. So what is actually OCT? Anybody? So OCT is similar to ultrasound, except in ultrasound you use ultrasonic waves. In OCT you use infrared laser waves to get a cross-sectional image of the point of interest. In neuro-ophthalmology, it is mainly the retinal nerve fiber layer and optic disc, and sometimes the macula. Yeah, so it runs on the principle of Michelson's interferometry, where you can see the low coherence light source is given, and there's a beam splitter. It splits into two beams. One beam goes into the retina, and the two things will happen. One is the time delay of the reflection of the structures, and other one is the intensity. So this wave which comes merges with the reference beam, and it is interpreted by a photodetector, and multiple A scans are being captured, which is converted into a B scan, and you get a picture. So what exactly happens in OCT is the time delay. Time delay determines what layer the structure is, whether superficial or deep. And the other one is reflectivity, whether it's high reflective or hyporeflective. So you can see the axial resolution is around 10 microns. So it gives so much of axial resolution. It takes multiple A scans and volumetric B scans. So there are several types of OCT, but as of now, currently we are using what? Spectral domain OCT. Yeah. So this is a broad classification of different types of OCT, where we usually use a spectral domain OCT, where you can get a scanning speed, you can see around 27,000 to 70,000 A scans per second, and the axial resolution is around 5 to 7 microns. When compared to previous OCT, it is much more advanced. So we use a spectral domain OCT. Okay, coming to indications of OCT, we use OCT in neuro-ophthalmology, and mainly three types of OCTs are used. OCT RNFL, that is retinal nerve fiber layer. So the primary tool for assessing the optic nerve head and measure the axonal loss, monitors the optic disc edema. Dr. Nirmala has shown what are the causes of optic disc edema, which can be evaluated by the OCT, and tracks the progression and also the prognosis. So OCT is mainly used to diagnose, to track the progression, to track the regression, and for prognostication. These are the four advantages and four indications of OCT. And coming to other second OCT, what you take is the OCT ganglion cell complex. As you all know, ganglion cell complex is the inner layer of retina. Complex means it has got one more layer. It contains GCC and retinal nerve fiber layer, the thickness of which is measured by ganglion cell complex. So it detects the early neuropathy. One thing I want to tell you is the earliest thing, any compression is there in the optic nerve, the earliest anatomical thing which goes is ganglion cell complex. Even before the retinal nerve fiber layer, the ganglion cell complex begin to reduce in thickness. So it's the earliest indicator for compression or atrophy. Then, not the least, you get a OCT macula. Even though macula is not directly connected with neuro-ophthalmology, but it aids in diagnosis. Some macular disease will have very minimal retinal findings, which confuses the clinician to know but neuro-ophthalmologic may be normal, but visual will be reduced. We don't know whether it's malingering or not. In such cases, OCT macula comes into picture to diagnose the condition. So coming to OCT, Dr. Nirmala showed in the previous slides. So clinical overview, this is the OCT RNFL. So RNFL is nothing but retinal nerve fiber layer. So apart from neuro-ophthalmology, the RNFL is being used to diagnose and evaluate a glaucoma. So in glaucoma also, the retinal nerve fiber is getting thinned out. So we see the difference, how to differentiate between a glaucoma and a neuro-ophthalmic disorder. So here is a picture so it measures around 3.4 millimeters around the optic. This is the optic disc. This circle is the measurement of retinal nerve fiber layer. Usually in glaucoma, you get a thinning in the inferior and superior nerve fiber. So nerve fiber defect is like a circle. So you get a superior, inferior, temporal, and nasal. One thing I want you to remember is, important thing is, in glaucoma, the superior and inferior nerve fibers are getting affected because they are magnocellular pathways, which is sensitive to pressure. So mostly the inferior is getting affected first. Whereas in neuro-ophthalmic conditions, the visual pathway lesions or orbital compression, the temporal and nasal fiber will get affected. This is temporal and this is nasal. This is superior, this is inferior. So in glaucoma, you usually get a superior or nasal defect. Whereas in neuro-ophthalmic condition, you get a temporal or nasal defect. This you should remember. So what is ISNT pattern? This is based on thickness. Normally the inferior is most thicker, followed by superior, then nasal, then temporal. That's why the inferior is getting affected by glaucoma first. So color coding is very important. So this is statistics. What you see, the red is within 95, red is less than 1% probability of it's normal, and yellow is the borderline. So 1% to 5% probability, and green is the normal. 95% of the population will be within this green. So whenever you expect a OCT, the dotted lines are the left eye and the non-dotted one is the right eye. So you can see a double hump sign. That means the inferior and superior are more thicker than temporal and nasal. So almost everything is within the normal limits in the green color. So it is normal. If you have a thinning, it will be in the red side. If you have thickening, it will be more in the white side. So here you can see more in the white side. So there's a minimal thickening of the retinal nerve fiber layer. So you can see these are statistics of the cup disc ratio, the volumetric analysis of the optic disc. All these things will be given here. And this is the average retinal nerve fiber thickness. Here you can see this is 120 microns. Normally it will be from 90 to 110 microns. If it's thinned, it will be less than 70 or 80. You classify it as thinning of the OCT. So you get a volumetric details of all the parameters. And here you can see the graph which shows which quadrant it is thickened or which quadrant it is thinned and in what statistical thing it falls. So this is the picture showing both OCT macula as well as this is the optic disc you can see. And this is the macula. You can see the foveal dip and you can see all the retinal layers. For a neuro-ophthalmic disease, you mainly concentrate on RNFL and ganglion cell layer. And for a macular disease, you mostly concentrate on retinal pigment outer layers of retina. That is RPE, outer plexiform layer, these layers. Neuro-ophthalmology concentrate on the inner layers of retina, mainly the GCC and RNFL. So coming to GCC, what is GCC? It's called ganglion cell complex. It's a thickness of both ganglion cell and RNFL. So you can see this in the macular area. This is optic disc. This scan is in the macular area. You can see the scan and you can see the color coding. So the red color indicates it's thinning, and more it is bright yellow color, it is blue color, it is normal. So you can see all the quadrants all in green color. So the thickness is normal. So you can see that volumetric thickness here, and you can see the contour of the macula. Everything is normal in this. So what is the importance of GCC? As I already told you, the ganglion cell complex is the first one to get affected before the RNFL. So it aids in early diagnosis and prognosis. Next comes macula. So when you take macula, you can see the normal macular dip. This is a foveal dip, and all the layers you can see this is a retinal pigment epithelium. So, so this is the ETTRS grid. You can see the 9 quadrants in the macular area, and you can get even a 3D reconstruction. So mainly macular disease, you take a ophthalmic disease, you take a OCT macula, but I already told you some neuro-ophthalmic disease may be confusing with macular disease. To rule out that, you have to take the OCT of the macula. So you can see all these photoreceptor complex layers and inner layers, which I already told you. And before interpreting the OCT, you should know the signal strength. The signal strength should be more than at least 7. So if your patient is having a cataract or something, the signal strength may be reduced and you may not get a proper picture. So it should be more than 10, 7. And centration should be proper, and all these false negative or artifacts should be ruled out before interpreting a OCT. So coming to use of OCT in neuro ophthalmology, we usually take the OCT RNFL for either to see whether it's normal or it is thickened or it is thinned. So as already Dr. Nirmala has told in previous presentation, use of OCT in disc edema. Disc edema, as everybody knows, that there will be thickening of the retinal nerve fiber layer. And before that, you have to classify whether it's a true disc edema or a pseudo disc edema. So she has told the causes. Now I'll just tell them how to differentiate in the OCT. So these are some of the causes: optic disc drusen, myelinated nerve fibers, and hypermetropic patients. So how to differentiate? Here you can see the picture of the fundus, where you can see multiple nodular lesions mimicking like a disc edema. And here in this picture, you can see a frank papilledema or a true disc edema. So I have compared the two OCTs. Here you can see there is a undulations. You can see multiple undulations and it's not regular. Whereas here you can see it is very much regular. Both are elevated, but this one is very regular. You can see it is. Here it is more serrated. And you can see there is a clear zone is abruptly ended. But here you can see the clear zone, it is angulation is there. You can see the small amount of clear zone is going into the retina as well. So this indicates the true disc edema. And here you can see in pseudo disc edema, there is a thickening of RNFL as well as thinning. Both are there. Whereas in true disc edema, there is no thinning as such in early stages. You can see only thickening. So if there's a mixed picture like this and serrations and undulations and abrupt ending of the retina, it's usually a pseudo disc edema. Mainly one of the important causes is optic disc drusen. Other cause of axonal edema is optic neuritis, papilledema, anti-ischemic optic neuropathy, compressive optic neuropathies, and infiltrative optic neuropathies. Here, so in papilledema, it's a diagnostic urgency. Here you can see the right eye. It's fully the retinal nerve fiber is totally thickened and is well above the green mark. So and thickness of eye also is RNF is also very much increased. So coming to non-arthritic ischemic optic neuropathy, you can see this is a ganglion cell complex showing a thinning. It's an old AON. So you can see a thinning in the ganglion cell complex. And other important indication of OCT is whether to classify the condition as acute or chronic. In chronic conditions, there will be thinning of the ganglion cell complex and thinning of the OCTs even with disc edema. In acute condition, it is thickened. So this is a compressive optic neuropathy. You can see there is a compression of the optic nerve. This is the ethmoidal sinus here near the apex of the orbit. You can see a central scotoma, and OCT shows this is the left eye. There is a thinning of the OCT and thinning of the ganglion cell. So it's a chronic compression. So RNFL thinning etiologies. What are the causes of RNFL thinning? As everybody knows, it's optic atrophies, primary, except secondary optic atrophy. Primary optic atrophy, traumatic optic neuropathy, and secondary thinning with neurodegenerative diseases, and consecutive optic neuropathy, which is secondary to retinal disorder like central retinal artery occlusion, causing a consecutive optic neuropathy. All these things causes thinning of the RNFL in the OCT, where you can see thinning, as I already told you, it will be in the red zone, and ganglion cell complex, you can see there is a multiple thinning. Okay, this is very important. OCT in glaucoma was a cavernous defect. What is cavernous defect? There is a cupping of the optic disc. You can see a enlarged cup. You can see there is a big cup in the optic disc. Mostly it is glaucomatous, but rarely it is can be due to compression of the anterior visual pathway like optic nerve compression, pituitary tumors. I have seen a patient which is treated as glaucoma for a long time, and ultimately it was a pituitary adenoma compressing the optic nerve, causing a cavernous defect. So how to differentiate? As I already told you, in glaucoma, the superior and inferior nerve fiber layer defect will be there. Whereas in case of compression, it will be temporal and nasal. And here it is a comparison. Non-glaucomatous optic neuropathy, the visual acuity will be reduced. In glaucomatous, in early stages, unless otherwise there is a glaucomatous optic atrophy, the visual acuity will be normal. The visual field defect respects a vertical meridian, which is a hallmark of neurological defect. Glaucoma, it will be a arcuate defect. It's a younger patient, it will be the older patient. This is very, very important sign. The pallor of the neuroretinal rim. This is the neuroretinal rim, the space between the disc and the cup and the disc. Normally in glaucoma, it will be normal, pink color. Whereas in case of compression or neuro-ophthalmic condition, it will be pale. So this is a very important sign. So these are the DD for cupping, compressive optic neuropathy, and sometimes arthritic, genital arthritis induced anti-ischemic optic neuropathy can cause a cavernous optic atrophy. And coming to GCC thinning, what are other conditions causing ganglion cell complex thinning is compressive optic neuropathy. I already told you, it's the earliest sign, earliest compression will be in the found out in the GCC before RNFL. Then glaucoma also can cause GCC thinning. Optic neuritis in late stages, not in early stages, can cause GCC thinning, and Leber's hereditary optic neuropathy can be diagnosed with ganglion cell complex thinning. So this is a picture. Thickness. One more thing I want to tell you is, can anybody tell what is this? There's no color photo is there, but well, you can see the thickness of both the eyes, RNFL is well above the normal. So there's a disc edema is there, bilateral. So this is a case of papilledema. But what you can see in the ganglion cell complex in the same patient is thinning is there. In RNFL, it is thickening. Ganglion cell, it is thinning. So what does it mean? Even though there is RNFL edema, there's a ganglion cell thinning. So it indicates there is a post-papilledema optic atrophy or secondary optic. This is very important. In case of pseudotumor cerebri IAH, if a patient is having disc edema, you always have to take in follow-up GCC, because we don't know whether it's going for post-papilledema optic atrophy or not, because it will take time for papilledema to resolve, RNFL edema to resolve. So how do you know whether it's going for optic atrophy or not? In secondary optic atrophy, where the RNFL is thickened already, you take a GCC. If GCC is normal, it's not going for atrophy. If GCC is thinned out in spite of RNFL being thick, it means there is going for secondary optic atrophy, and your management has to be ramped up. Either it's a CSF shunt or surgical management has to be taken. And of course, fields also has to be taken to complement your diagnosis. So this is a normal RNFL thickness, 85 to 115 microns. GCC is 95 to 115 microns, 2 minutes. And when it's less than 73, it indicates a poor prognosis, and GCC thickness less than 58 micrometers, poor prognosis. This happens. Neurosurgeons usually ask, I'm going to do a decompression surgery, whether the patient will improve or not. So what you have to tell is, you have to look out these parameters. If it is less than 73 and GCC less than 58, the recovery for vision even after a successful decompression is less. So OCT is indicated for prognostication also. So this is a macular lesion mimicking the neuro-ophthalmology. As I already told you, sometimes a macular lesion subtle macular lesion mimic like a neuro-ophthalmic disorders. So these are some of the conditions: ischemic maculopathy, photoretinitis, AMN, paraneoplastic retinopathy. All these things, the fundus looks almost normal, but patient will have defective vision. You don't know whether it's a malingering or neuro-ophthalmology or something. In such cases, the OCT is very much useful. So how you can differentiate in neuro-ophthalmology? Primary OCT scan, you do a RNFL study where main abnormality is thickening or swelling. In macula, there is retinal architectural changes. The layers affected in macula are mostly, I told, outer retina, whereas in neuro-ophthalmology, it is the inner retina. And macular contour is usually preserved in neuro-ophthalmology, whereas in macular disease, there will be subtle distortions. Okay, I'll finish with this. So as a nutshell, you take a OCT in suspected neuro-ophthalmic disorders for diagnosis, for prognosis, and for follow-up. Thank you so much.
Thank you, Dr. Stephen, for the excellent talk. Next talk is on imaging in optic neuritis by Professor Gopinathan. He is the professor and Nathan to proceed.
Very good morning. Thank you for the nice introduction. We'll go into the topic proper. So my topic is optic neuritis imaging. So before going into the neuritis proper, so we have to know the normal anatomy. So what is the normal imaging modality we will do in respect to optic neuritis? So MRI is the gold standard. In MRI, I will tell you what all the sequence we have to take it, and this is on anatomical MR. You can see that we have to see all the four compartment of the optic nerve. This is the intraocular, the intraorbital, and intracranial and the cysternal prechiasmatic region. You have to see how they're normal or not. And coming to the sequence, what are when you come for orbital imagings, the optic nerve imaging, you have to think eye is an extension of the brain, and you have to think as a spine is an extension of the brain. So that whenever you finding the lesion, you have to search the lesion in the brain and also in the spine. So it's you have to see entire neuroaxis. You should not limit in your field into the only the optic nerve only. Okay. And also when you are giving suspecting optic neuritis, not only you look at the plain scans, whenever having the clinical suspicions, always you have the contrast enhanced MR. See why I am telling is here you can see the here only you are seeing the only the perineural enhancement is there. There is no intraneural signal abnormality. Here you can see the intraneural signal abnormality. Here only you are seeing the perineural signal abnormality. That's why you have to give all the cases suspected optic neuritis. You have to give the IV contrast, and you have to include the brain and the spine is either one of the sequence. Okay. So coming to the optic neuritis, you know that the inflammation of the optic nerve. So you will have the triad of symptoms like a vision loss and the periocular pain, a dyschromatopsia is there, and you have to differentiate optic neuritics from the optic perineuritis. So this is very important since the optic neuritis and the perioptic neuritis sometimes will have the same symptoms. The only thing is, if you see classically, if you look at the central scotoma in optic neuritis, if you're looking at the optic perineuritis, you'll have the paracentral scotoma will be there, and you can see if you're looking at the MR, you can see the intraneural. There is a signal abnormality. The optic nerve enhancement will be there. If you're looking at the optic perineuritis, the nerve will be normal. Only the perioptic sheaths are enhancing. This is the classical of optic perineuritis. And even why it is important as a treatment also, most of the optic neuritis recovers sometimes spontaneously, whereas the optic perineuritis spontaneous recovery is less likely. And if you even without the steroid therapy, it will become normal some of the cases. So coming to the optic neuritis, so whenever you see finding the optic neuritis, you have to tell whether this anterior is involved. There is a papillitis is there. The posterior in the optic nerve, the retrobulbar involvement is there. Even in the optic nerves, we have to tell whether there's a short segment involvement or a long segment involvement. How will you tell the long segment involvement? If it is more than or equal to 3 long optic nerve segments, or if it is length of involvement is more than 4 centimeter, or if it is more than 50% of the optic nerve length is there, we can call it as a longitudinal extensive optic neuritis. So optic neuritis, we know that there are 3 important diagnostic things. One is NMO, defects, we call it MOGOD, and the MS. So you can, the very classical thing will be, you can see the NMOSD, you can see the posterior aspect involvement. MOGOG, you will see the anterior aspect involvement, and you will see the multiple sclerosis. We can see the retroorbital compartment, spot segment, small lesions will be there. So coming to the optic neuritis, the most common disease will be the multiple sclerosis. So multiple sclerosis, if you're looking at this MR imaging pattern, you can see that there is an enhancement of the optic nerve is there. And whenever yes, I told I have to look at the brain, and brain you can see the dorsal finger like periventricular lesions are there. So now according to the McDonald's newest criteria, the optic nerve involvement is included as one of the criteria in dissemination in space. So that's why even if you're single optic nerve involvement with the other clinical symptoms or the CSF parameters, we can give the diagnosis of MS straight away, rather than previously we call it as a clinically isolated syndrome. Okay, so that thing you have to keep in mind. So optic nerve involvement, along with this, you have to look at the brain. So brain, you are seeing the dorsal fingers, not only the periventricular, the supratentorial, and the infratentorial, and the spinal cord lesions. So more than 5 disseminations by space lesions are there. So confident diagnosis of MS without asking any investigations, we can give diagnosis for the straight away without giving any other norms. Okay, we can start the diagnosis. So classical in multiple sclerosis is usually unilateral and also a short segment involvement. So unilateral and short segment involvement, and the prechiasmatic region usually spared in multiple sclerosis. Okay, so coming to the next disorders, as a neuromyelitis optica spectrum disorders. If you're looking at the histories, the bilateral, see, the bilateral nerve involvement. And looking at this, and the nerve involvement is against longitudinal extensive involvement, and if the involvement will be the in the pre-chiasmatic and the posterior aspect of the optic nerve is classically involved. And the thing is, if you know that this is due to the acroporin 4-channel water channel related things. That's why the acroporin related areas, there is a periventricular area in the third and the fourth ventricle regions are involved. So you have to look at the brain. So what all the areas are involved? You can see there is a bilateral. It can be a unilateral. It can be unilateral. The posterior involvement can be a bilateral posterior involvement pre-chiasmatic segment. So the classical involvement in NMOSD. And other demyelinating disorders, you have to think whether there is MOGAD. So MOGAD is the one can involve the both optic nerve and the perioptic sheath. So if you see the optic nerve involvement, the central aspect of the optic nerve is involved. Along with this, if you give the contrast only, we can tell the perioptic sheath involvement. There is a perioptic sheath is involved, and if you find if you subject the patient has turned out to be a MOGAD. So MOGAD can present as any form. Can in brain it can take as any form. That you have to keep in mind. And other important newly recognized demyelinating disorders. So you can see there is a again, it is a longitudinally extensive optic neuritis, bilateral optic nerves are involved, and there is a patchy nerve enhancement, not a uniform as the previous cases, the patchy nerve involvement. But look, turn on to the brain, what you are seeing, there is an enhancement in the multiple perivascular space of the brain is enhanced. Not only the multiple perivascular space, if you look at the spinal cord also, that is heterogeneous patchy enhancements and all. Is appropriate clinical settings. This case happened to be the classic lab. What disease? Anyone? So it's a classic lab, GFAP astrocytopathies. Okay, the classical perivascular, this is demyelination, very classical thing, small thing, and the heterogeneous linear enhancement. Not only in the brain, optic nerve also, it will behave the same kind of appearance. Okay, so as you summarize the demyelination, so you can see the MOGAD related things, you can see the optic nerve and also in the perioptic sheath involvement, predominantly on the anterior aspect. And you can see the NMOSD, you can see the predominantly in the posterior optic nerve and the pre-chiasmatic region is involved, and the acroporin related channels, the periventricular regions are involved in the brain. And if you're looking at this MS, you can see the unilateral and short segment involvement. Along with this, you can see the classical dorsal finger and the supra and infratentorial location. And other edema also can sometimes acutely present as optic neuritis things. As you know that nowadays, edema is an extension of the MOGAD. So that's why I didn't tell as a MOGAD, edema is a different thing. Okay. So not only in demyelination, sometimes classical infection-related things. So you can have this kind of neurosyphilis, you can have the Katz's disease, you can see some drug-related, ethambutol-related toxicities, all presented as optic nerve enhancement, optic nerve involvement will be there. Okay. So this is very difficult to differentiate from this, and this thing we have to do extensive examination and clinical history will tell this kind of thing. And coming to this ischemic neuritis, as Madam already told, that the sudden painless vision loss, you have to tell whether the anterior ischemic, we have to look at the diffusion weighted imaging here. You can look at the diffusion weighted imaging, you can see the anterior nerve head there is a diffusion restriction is there. You can tell most likely to be a anterior ischemia or neuritis. So coming to this next spectrum is the perineuritis. So as I told, perineuritis, if you're looking at this, T2 weighted imaging will be normal. So only thing is, so T2 here you are not able to differentiate any pathology here, but by giving the contrast, what you are seeing is there is a tram track enhancement is there. Along with the tram track, if you look at the coronal sections, you see the donut-like lesion. So this perineuritis is there. So in the old age patient, this classical and clinical history, you can think of giant cell arteritis and perineuritis. And other inflammatory disorders can involve sarcoidosis, can involve this kind of appearance. This you have to keep in mind. So not only the optic neuritis, so we have to look at the differential diagnosis of same kind of clinical symptoms. So here we can see there is a tram track like enhancement is there. So you can here also you can see the same kind of ring-like enhancement. So it is a perineural enhancement, but the perineural enhancement, this is causing mass effect over the nerve. Mass effect over the nerve, you can see there is a And also you can see there is a hypo-intense area. Here you can see the hyper-intense area. So there is a hypo-intense, T2 hypo-intense. So whenever if you see T2 hypo-intense area, you have to think of any fibrosis or calcification. If you turn on to CT, you can see the tram-track calcification will be there. This sometimes if the early meningioma, optic nerve with meningioma can mimic the same. So that this kind of patient you have to take the CT, and also you have to see whether the enhancement is extending into the optic nerve or extending into the brain or duro. You can confidently tell this optic nerve with meningioma. And the other thing, this kind of it's a known case of some neurofibromatosis disorders. You can think of optic nerve glioma, also one of the differential diagnosis. You will see the enhancement and also the expansion of the nerve in these cases. And coming to this other thing, if you known cases of leukemias, you can say looking at the leukemic optic neuropathy, you can see the lot of deposition of the leukemic deposits over the retro-orbital plane, and also the optic nerve enhancement will be there. These things you have to keep in mind. And to summarize, so MRI, the contrast study is essential. Don't order only plain study. And if you see some lesions in the brain, so you have to screen the brain and the spinal cord with a meaningful diagnosis. And if you are looking at the optic neuritis, you have to tell whether only the optic neuritis or a perineuritis is there, or both optic neuritis and perineuritis is there. So these different diagnoses will differ. And looking at this, I can differentiate whether the anterior involvement or the posterior involvement, with a unilateral or a bilateral or a small lesion or a long segment lesion. If it is a small lesion, unilateral, it has to be a MS. If it is a bilateral, if it is a long lesion with the posterior involvement, it's a NMO. It's a bilateral, and if you get the anterior involvement with the perineural component is there, it's a MOGAD. And also remember that other diseases like infectious, inflammatory, or ischemic neuritis can sometimes overlap the findings, and you have to know the differential of the optic neuritis. So with this, thank you for giving me this opportunity.
Yeah. Is Dr. Deepak Arjunas here? Hi, Deepak, come. Welcoming to Dr. Deepak Arjunas, Senior Neurologist at Mercury Hospital and Vijaya Health Center. Please go ahead, Deepak.
Good morning, everybody. Okay. Good morning, everybody. Thank Vasudevan. Thank Shivatsan and Rupesh for inviting me to give this talk on medical management of optic neuritis. What's the treatment goal? We know the treatment goal for optic neuritis is to reduce optic nerve inflammation and address underlying causes. Vision often improves in its own within several weeks to months. What does medical management do? It is used to speed up the recovery and further treat underlying conditions. What about the acute treatment? What is the strategy? We use high-dose corticosteroid as the mainstay of treatment. However, oral steroids alone without an IV are usually avoided, as they may increase the risk of conditioning returning. What about the phase 1? What do? We use IV methylprednisolone, 250 mg 4 times a day for 3 days or up to 5 days. Following it up with an oral prednisolone 1 mg per kg for 11 days, and then a steroid tape on the third phase. We can also use methylprednisolone 1 gram per day for 3 to 5 days, or oral prednisolone 1050 milligrams OD for 3 to 5 days. It's an atypical, for atypical optic neuritis, you need a prolonged steroid therapy and a slow weaning, which may take up to 6 months, depending on the patient. The main benefit of high-dose steroid lies in hastening recovery time and preventing recurrence. The final visual acuity, visual fields, and contrast color perception may not be improved. What about patients that don't improve? We need to do an escalation. 2 escalations are there, PLEX and IVIG. If vision loss is severe, persistent, and unresponsive to steroid treatment, we use plasma exchange. Also may be considered as a viable option in demyelination of optic neuritis that is unresponsive to steroids. Early treatment within 3 weeks will be beneficial for PLEX. Don't wait for too long. Two types of plex are there. One done in our hospital with the dialysis department, one with the hematology department. The plex done by the blood bank is more effective, especially when you use a filter. What about the chronic treatment of underlying causes? Typical operations are also often linked to conditions like MS. Initiating appropriate disease-modifying therapies also may be helpful in clinical isolated syndrome. The choice of treatment depends on the severity of ON, autoimmune and inflammatory disease activity, comorbidities, and etc. The available treatment options include platform therapies, interferons, teriflunomide, moderate efficient drugs like DMF, fingolimod, high efficient like the MABs, which are present and available from time to time in the market. What about the recommended dosing and regimes? If you use interferon alpha, you can use it IM once a week. You have the pegylated one, you can use once in 2 weeks, or the betaferon, which is the beta 1 beta, which is used on alternate days. Teriflunomide is quite a good drug, smooth drug for small cases. We usually start off with 7 mg alternate days for a week or two, escalate to 7 mg daily for a week or two, then get on to the full dose of 14 mg daily. Dimethyl fumarate, I start off with 120 mg once a day for a week, then make it twice a day for a week, and then make it 240 mg twice a day. Fingolimide for less than a 40 mg patient, 0.25 mg orally, and more than 40 mg, 0.5 mg orally. Oxalimab, good chip on the block, at 300 mg on day 1, call him back for day 15, 300 mg, then follow up 600 mg every 6 months. Otomab is available 20 mg subcut on week 0, 1, 2, 4, and then followed by 20 mg every month. Narslimab available even in the government hospitals, 300 mg every 4 weeks, but make sure your PML status is negative. I use a lot of rituximab. I give it 1 gram IV a month apart, those recommended 15 days, followed by 1 gram to 500 milligrams every 6 months. Keep a look at the CD19-20 count. The rhythm dosing regime is not fixed, and the dosing depends on the CD19 counts. What about atypical optic neuritis? Often linked to neuromyopathy syndrome disorder or MOG syndrome associated with MOGAD. For NMO of ON, if equivalent 4 is positive NMO, complement inhibitors can use eculizumab or rituximab. If anti-CME monoclonal antibody, can use invizumab. For IL-60 receptor inhibitor, use satralizumab. Or alternate off-label, you can still use rituximab, which is heavily utilized globally due to the proved B-cell depleting efficiency. For NMO, if AQ positive negative or seronegative NMO SND, rituximab is the first line of drug for double negative NMOSD. You can use mycophenolate, starting with, I start with less small, thin person, 250, 500, and you can increase every week until you get up to 1 gram twice daily. Azathioprine, not very expensive, 2.5 to 3 mg per kg body weight per day. Start off with 25 mg daily and increase to 50 mg in steps every 1 to 2 weeks. Unfortunately, majority of the acupuncture for positive NMO drugs are unable in India, may be treated useful in seronegative NMOs. The recommended dose on the MABs are eculizumab. Their doses 1 to 4, 900 grams IV weekly for first 4 weeks, followed by dose 5, 1000 milligrams IV 1 week later, then 1200 milligrams week thereafter. Inluzumab, 300 milligram dose, initial dose, 2 startup doses, 2 weeks apart. Then you maintain every 6 months. Rituximab, I said we use it on day 1 and I use day 13. We repeat it approximately once in 6 months per year. Luizumab, depending on the body weight, we start off a body load of 40 kg, go to 2,400 and then maintenance of 3,000. If you're more than 60, you increase it to 2,700, go up to 3,300. More than 100 kilos, you need up to 3,600. Satralizumab, you need 3 loading doses, week 0, week 3, week 4, and then you need a maintaining dose every week. Rituximab dosing regimes is not fixed, used off-dating setting. Dosing adjustment depends on CD19 and B cell counts. Chronic treatment of underlying count for non-NMO-ON, similar regimes as that for seronegative NMO may be used. Cyclophosphamide may be useful in lupus optic neuritis, pulse protocol of 800 to 1000 milligrams per meter square monthly for about a year or 2. Infliximab in sarcoid optic neuritis, use a dose of 5 mg loading dose on day 0 to 4 weeks, followed by 5 mg every 2 months for about a year. Usage is off-label with no fixed regimen, ranging from 3 to 7 milligrams for dosing regime. What about the outlook for neural regeneration? Erythropoietin in the group of optic neuritis, we found have reduced RLF thickness. Simvastatin for optic neuritis for neuroprotection, it had reduced VEP latency, increased VEP amplitude. Autologous mesenchymal stem cells for secondary progressive MS, reduced VEP latency and increased optic nerve area. Phenytoin for optic neuritis, in progressive outdoor reduction of OCT and RLF loss. Amyloidide for optic neuritis, in progressive primary outcome, reduction in OCT and reduced loss of RNF. The anti-LINGO antibody for remyelination and on progressive primary MS has reasonably good outcomes. Thank you so much for this opportunity to share my thoughts on optic neuritis. Just to tell you, steroid treatment in optic neuritis is like a monkey, like Hanuman. Like you had Lord Rama who got married to Sita and then Sita goes away to Sri Lanka. Then you need a small monkey to bring her back, right? You don't need, he can't go get her back. So steroid in optic neuritis is like a Hanuman. You use it for an acute phase, you use it judiciously, and you ensure that you give 3 days, 4 days, 5 days, you give adequate dose, preferably give it under supervision because you can give it as outpatient, but we have had patients with fulminant cellulitis when given in the leg and we had to amputate the leg. So it's a wonderful drug, use carefully, use judicially, you will get very good outcomes with steroids. Thank you so much.
Thank you, sir. Thank you for the lucid presentation on optic neuritis management.
With that, we come to the end of the session. Thank you very much.
Thank you to the chairpersons for facilitating this session. Now, we shall move on to the inauguration ceremony. May I request everyone to kindly remain seated. I kindly request the dignitaries to join us on stage. Dr. Rajesh Ratanlal, Director of Medical Services, Dr. Nanda Kishore, Clinical Director, Dr. Annabel D'Souza, Vice President Quality, and Dr. Prashant Rajagopalan, Managing Director of MGM Group of Hospitals. To join us, I also invite Dr. Rupesh and Dr. Vasudevan, sir. I request everybody to stand up for the Dhanvantri song, which signifies God of healing, as we light the lamp.
धन्वन्तरि स भगवानमृतत्वदाता यो वैद्यकस्य गुरुरादिरनादिकालात् योगात् देहमन आत्मसुखावहस्य नैरोग्यदस्य नितरां च निनाहितस्य तस्याहनास्पदमहर्षिवरस्य शिष्या एते वयं प्रमुदिताननुभाग्यवन्तः तेन प्रदीपितचरं शुचिचाशुभायुः वेदस्य दीपमिह तत्पुरतो धरामः येन प्रभां वयमिहास्य वितत्य दिक्षु ज्योत्स्नां रुजाति शमनीं प्रभवेम दातुम् व्याधिव्यथार्थ हृदयाय हि मानवाय ध्येयं त्विदं भुवि कलापि च न किलैष ध्येयं त्विदं भुवि कलापि च न किलैष ध्येयं त्विदं भुवि कलापि च न किलैष
I request our dignitaries to facilitate the lighting of the lamp.
Thank you, sir. On behalf of the Departments of Neurology and Neurosurgery, we invite Dr. Sudhir Kothari, who has been kind enough to join us through the Zoom session. Sir is from Pune and he is currently the President-elect of the Indian Academy of Neurology. Welcome, sir.
Sudhir, you are muted.
My talk also not well. So,
Welcome, welcome. I hope you can see us. Are you all right enough to speak a few words?
yeah, I will, of course. I'll So I saw the whole program. It's an excellent one, and I just could hear Deepak just now finishing his optic neuritis one. So I actually spoke with Madhu yesterday, and we had coordinated, and he was going to talk on the higher center control of vision, the higher vision problems, and I was all ready to somehow give a talk on eye movements because it's a huge topic, and I was trying to squeeze it into 20 minutes, but I'm sorry I could not do it. So sometime again later.
Yes.
I wish you all the best for this excellent, very brief but totally very comprehensive update. And I'm sure everybody is going to learn a lot. Thank you.
Thank you very much. Thank you. Thank you for joining us.
Thank you, sir. I invite Dr. Aarti Deepesh, Clinical Lead, Neuroimaging and Interventional Radiology and Secretary of IMA, MGM Healthcare Branch, to recite the IMA prayer.
May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thanks.
Thank you, ma'am. I kindly request Dr. Vasudevan, Director of Neurology and Neurophysiology, to deliver the welcome address.
Good morning, everybody. At the outset, I would like to thank Dr. Prashant, our MD, who is here and who has always been encouraging us to conduct such programs. And since I have joined this organization, we have already had 3 CMEs. So that is saying a lot. This program on neuro ophthalmology was conceived and developed by Dr. Rupesh, and along with my colleague Dr. Srivardhan in neurology, and our radiology colleagues as well as ophthalmology colleagues. And it's an extremely comprehensive program. I would like to welcome all the distinguished faculty members who have taken their time off to be present with us and to share their knowledge and experience with all the other delegates who are present here and all the other faculty members who have also joined us today. Neuro-ophthalmology is a fascinating field. It is at the crossroads of neurology and ophthalmology, and it is growing by leaps and bounds, not only in terms of clinical development and clinical, the knowledge that we get by virtue of knowing more about the underlying physiology, like what Dr. Madhusudanan so aptly described in his talk on the higher visual pathways today morning. Not only that, but also by the advent of newer diagnostic techniques like OCT, which was described, and imaging modalities, which have played a great role in advancing the therapeutics in neuro-ophthalmology. And this program has been designed primarily to help improve the clinical acumen and skills of not only the practicing physicians, but also the postgraduate students who have also joined us here today. And I welcome all of you to this program, and I'm sure this will be of great help to everybody. Thank you.
Thank you, sir. I kindly request Dr. Rupesh, Director of Neurosurgery, to say a few words about today's program.
Good morning, everybody. At the outset, I thank everybody who has assembled here on our invitation. It's extreme honor and pleasure for us. I should especially thank Dr. Prashant and the management of MGM for helping us to organize such an event in a very short time. Actually, this hall is supposed to be, it's a dining area. Many of you would have come for earlier meetings, and our academic meetings happens in the other room. And we requested Dr. Prashant that the roof is small. So he immediately gave a suggestion, why not we do it here and can cover it up. And then we can see the venue has been now so nice. And I think many of our departments also will follow. And yesterday evening only we arranged all these things. And evening when we went back, we saw that it's so astonishing to see such a very good backdrop as well. It's a natural backdrop, but then it looks much more with grandeur with this screen also. Coming to our CME, so all of us do CMEs regularly in our own specialities. But what is happening in the healthcare today is called the Rashomon effect. Rashomon is a very famous Japanese movie. It's an eye-opener for many of the movies, and it is still quoted, wherein one murder happens and four different witnesses give their own perspective, but nothing actually correct. Many movies have taken up in that line. Andanal is a very famous Tamil movie, which is almost a telecopy of that movie, and we have many such movies which has come up. The basic idea is that we should not fall a prey like five blind people palpating elephant and interpreting our own way. It's always better to have a group discussion, and that is the whole idea of this multidisciplinary team, wherein four different specialities, neurology, neurosurgery, ophthalmology, and radiology, come together and diagnose, treat, and give the best outcomes to this patient. So I think more and more we should have multidisciplinary meetings rather than confining to our own system. So I think this is the first time we are doing, and we have a series of such meetings. In another 2 months, we have a neuro rehabilitation, and then we have neurocritical care, and then a functional neurology, neurosurgery. In this year itself, we are planning it out so that different specialties come together and for a common goal of learning, sharing our experience, and then taking it back to our patients. So these few words, thank you. I hope you will all enjoy the CME, and thank you very much for again joining us.
Thank you, sir. I kindly request Dr. Prashant Rajagopalan, Managing Director, MGM Group of Hospitals, to say a few words.
Good morning, one and all. It's a pleasure to join you this morning. I would like to thank Dr. Rupesh, Dr. Vasudevan, as well as the radiology and ophthalmology team of MGM Healthcare in putting together this multidisciplinary CME. And as Dr. Rupesh rightly pointed out, this is the third such CME from the neurosciences department just this year, and we have 3 more coming up, which is very close to our mission of actually not just doing exceptional clinical work, which we do day in and day out, but also work on spreading awareness, but more importantly on thought leadership in the space of neurosciences, where we have been fortunate to be ranked quite highly. Before I go on to speak anything further about the CME or about Dr. Rupesh, I would like to cite a small story from Mahabharata, where in the battle of Kurukshetra, Arjuna is fighting someone, and he has taken a vow to finish the battle before the evening, in the absence of which he decides to immolate himself. And Krishna, to ensure that Arjuna actually succeeds, uses his Sudarshan Chakra to cover the sun and create darkness so that he is able to achieve his purpose. Basically what Dr. Rupesh said, but with a historic anecdote, which is this is meant to be an open atrium, open to sky, and all those are patient rooms where natural light comes in. But when Dr. Rupesh made a very compelling case saying that, listen, for a CME or conference of this nature, we want a much larger platform. We made it happen overnight. And this is just a small example of what we will do for Dr. Rupesh or for the department, because we owe a lot to him. You know, in terms of values, we are very well aligned with the entire Department of Neurosciences. You know, each of them, both the HODs, come from academic institutions, having been HODs. And this year, we celebrate our 25th year anniversary of our university. And our background, our humble origins come from medical education in disseminating knowledge to the next generation of doctors, surgeons, physicians. And it is very close to our heart when our doctors here go above and beyond their primary responsibility of treating patients. And I call it primary because each of us, when we reach a certain stage in our career, we think about how do we give back to our fraternity. And one of the many ways in which we can do that is by organizing such conferences and CMEs where the next generation leaders are here and you share your knowledge and create a spark in them, and which is how MGM came about to being. Case in point, we have been consistently ranked amongst the top 5 private hospitals in the country by the by the Outlook magazine. And this year we are happy to share for the 3rd time in a row, we have been ranked number 1, sharing the rank along with the oldest private hospital in the country, which is again from Chennai. And this would not have been possible if not for the exceptional clinical team that we have been blessed to have here, be it Dr. Rupesh and team, Dr. Vasudevan sir and team, or the so many people who are part of the team who are not on the dais, who are off the dais, Dr. Srivardhan himself, who has been such a young and guiding force behind neurology here. So we are blessed to have such a great team, and we find pleasure in supporting their initiatives. I am no subject matter specialist, which is clearly why I've been digressing, talking about Mahabharata, about MGM, but I don't have much to speak about neurology, neurosurgery, or ophthalmology at the least. But we will always stand behind our teams in their endeavor to create such events, and that is the only reason I'm here, sir. And I wish the program all the best, and I hope
Thank you, sir. As a token of appreciation, we will be now giving a token of appreciation to our esteemed speakers. So I call upon Dr. Rupesh Kumar to present a memento to Dr. Prashant. I request Dr. Vasudevan to present Dr. Ratanlal Rajesh. I call upon Dr. Aarti Deepesh to facilitate Dr. Nanda Kishore with a memento. I call upon Dr. Suhasini to facilitate Dr. Annabelle with a memento and to also deliver the vote of thanks.
Good morning. On behalf of the organizing committee, I would like to express our gratitude to the Managing Director, Dr. Prashant Rajagopalan, the Director of Medical Services, Dr. Rajesh Ratanlal, the Clinical Director, Dr. Nandakishore sir, and the Vice President Quality, Dr. Annabelle Madam. Next, we express our heartfelt thanks to the panelists, speakers, and faculty for sharing their expertise in their respective fields. We also thank the delegates and participants for showing up in large numbers. We also express our thanks for all the affiliated societies, the Indian Medical Association, the Tamil Nadu and Pondicherry Association of Neurologists, the Tamil Nadu Ophthalmic Association, the Tamil Nadu Association of Neurological Surgeons, and the Tamil Nadu and Pondicherry chapter of Radiological Imaging Association. We would also like to thank the administration and operations team for their support. We also extend a warm thanks to the branding and marketing team, food and beverages, and the IT team who have worked tirelessly towards helping us with the smooth organization of this event. We also thank the security and housekeeping teams at this point. Last but not least, we thank our primary sponsor, Sun Pharma. Thank you.
Thank you, sir. Thank you, one and all. We'll resume our academic session. Due to want of time, the coffee and tea will be served here. We'll go to our Symposium 3. I now request the chairpersons of Symposium 3, Dr. Karthikeyan. Dr. Karthikeyan can come forward. Dr. Ambika Selvakumar and Dr. Murali Krishna. I request the three panelists to come forward. The first talk would be delivered by Dr. Balaji, who's from Chengalpet Medical College, on medical management of idiopathic intracranial hypertension. Thank you.
Respected chairpersons, my teachers, very good morning to you all. If the purpose of this CME is a multidisciplinary one, I think the very apt topic would be management of idiopathic intracranial hypertension, which involves neurophysicians, ophthalmologists, neurosurgeons, neuroradiologists, endocrinologists, and so on. So a typical IIH, for the benefit of postgraduates, we start with a headache which is not very typical for IIH. We have a papilledema. We have seen in the morning how to look for a papilledema and to grade it. And the clinical sense, usually you don't have any long track signs. For a neurophysician to diagnose a IIH, it all starts with a papilledema with no lateralizing clinical signs. Of course, you can have a sixth nerve palsy. You have various radiological signs, and the CSF content will be normal, and the pressure will be more than 25 centimeters of water. They're typically females, obese, and of childbearing age. That's a typical IIH. If it is in a male and non-obese and of an extreme age, you call it as an atypical IIH. If there is a sudden decline in visual function, you call it as a fulminant IIH. You can have IIH without papilledema. So IIH patients, during remission, the papilledema resolves, the clinical features resolves, and headache alone persists. That's called IIH in ocular remission. So I'm going to because of the want of time, I'm going to touch up all the essentials in diagnosis and monitoring, weight loss, medications, headaches, and special situations. So with respect to diagnosis and monitoring, it has been said that whenever you have a papilledema, BP is very important. Blood counts are very important for anemia and polycythemia. The statement I want to make is severe grade papilledema and visual acuity impairment at presentation. They are the high-risk patients. The headache severity and papilledema do not correlate. And it's important, mandated to do an MRV in all these patients. These are various radiological signs which you can refer to. And the fallacy on the measuring the ICP, always in a lateral decubitus position, the legs should be extended, the hip should be extended, it should not be flexed. All these things can cause a mild increase in ICP. And there is a gray zone between 25 and 30. Though the cutoff value is 25, you can always take 30 as a value. It's very important to monitor these patients on a regular basis. The clinical monitoring includes the visual acuity, the color vision which has been stressed in the morning. The pupils, any RAPDs need to be looked into, extraocular movements for a sixth nerve palsy, and fields by confrontation. I think it was alluded well in the morning. So most important thing is the formal perimetry. All these things are secondary. It is important that you ask for a frequent or at least a couple of field evaluation in these patients. Fundus examinations, OCT has been stressed in the morning. You can do at various places. The RFNL or the ganglion cell layer. We have seen the differences, where to look, and in the previous presentation. So a word on spontaneous venous pulsations. If they are present, it gives a good prognosis that the vision is not at risk. Going on to weight loss, the cutoff is the BMI is 30. It is important to look at BMI in all these patients, not at diagnosis and also during follow-up. The place where the BMI takes off is 30. 30 is considered to be a very critical BMI, wherein when it is above 30, very aggressive weight management system needs to be inculcated. So weight management is the only disease modifying treatment in IIH. So it is very, very important that we stress on this sensitive aspect to inpatient management. So in patients with more than 30, it is almost mandatory. The weight reduction should be attempted. 5 to 15% is what the weight reduction we aim at. It is done by about 500 to 1,000 kilocalorie per day deficit in calories. Salt restriction doesn't help actually, though it helps in reducing the extracellular fluid volume. It's the adipose tissue that's important. So salt restriction is not helpful. Any 15% reduction reduces almost the ICP, headache, as well as there is an improvement in vision. So the latest thing in the domain is the GLP-1 analog. So we know the the endocrine activity of GLP-1, but most important thing is that they do have a direct action on the choroid plexus. They can decrease the secretion of the CSF secretion, this GLP-1 analog. So on acetazolamide, the bottom statement is that acetazolamide is not better than placebo in improving headaches and visual acuity. Though it improves visual fields, papilledema, and vision-related quality of life, it is not better than placebo in improving headaches and visual quality. So the dose of acetazolamide used in IIH treatment trial is up to 4 grams per day. Only 40 to 50% of people, they tolerate these doses. But the most important thing is counsel about the side effects, the tingling paresthesias, as well as change in taste sensations. They help us to adhere. And one important thing is that though acetazolamide is a sulfa allergy doesn't prevent us from giving acetazolamide because the sulfa moiety is different here. So there are limited evidence for other drugs like topiramate, acetazolamide, amiodaride, octreotide, and furosemide. Topiramate is supposed to decrease the ICP even more than acetazolamide, can be used in appropriate patients. Regarding headache, there is no IIH specific headache phenotype. Most of them are migrainous. Medication overuse headache needs to be considered. Again, even in the acute stage, at the time of diagnosis, the management of headache depends on the lumbar puncture or any decrease in the CSF pressure. Again, you don't have any specific clinical character for this headache. Whereas in a chronic setting, the important message is that acetazolamide does not help headache treatment during chronic phase of IIH, because most of these patients, it's something like a sensitization trigger. Once you have an IIH, many of these patients continue to have chronic headaches, and acetazolamide is not helpful, and you have to reclassify these headache and move forwards. So whenever you have a headache, think about an elevated ICP, a migraine in these patients, medication overuse, and if it has been previously shunted, whether it is a pressure-related headache, and so on and so forth. So some special situations, oral contraceptive pills, though traditionally thought that they can cause IIH, they do not cause IIH. Only the weight gain that is associated with IIH causes weight gain associated with the OCP cause the IIH. Topiramate has a teratogenic risk, acetazolamide does not. And on the obstetric care, the IIH imparts a significant risk of gestational diabetes as well as preeclampsia. They needs to be taken care of. mental health needs to be taken care of because they have an associated depression, anxiety, they have increased suicidal risk. So IIH without papilledema is you don't have a papilledema, other features are there, including the radiological features. I just want to allude a small study which we have done in our Chengalpet Medical College by using the transcranial Doppler in patients with these IIH. We have followed a few of them. The postulate is that the pulsatility index depends on the vascular resistance. If you have an increased pressure, the vascular resistance increases, so the diastolic flow decreases, wherein the pulsatile index increases. So we followed a group of 10 patients with IIH. We did a baseline before the CSF tap, as well as we followed them with serial TCD scores on pulsatility. What we found was there was a significant increase in the pulsatility index before diagnosis, which promptly reduced after treatment, which is not a surprise. But the most important conclusion we had was that these patients, they go on to have repeated headaches. One conclusion we had was that given the higher incidence of migraine in these patients, TCD-PI estimates in headaches during follow-up of these IIH patients can help in sorting out this headache. We can be rest assured that the recurrent headaches are not due to increase in CSF pressure. But the most important thing in the management of the IIH patients is following them for their visual symptoms, especially with the field charting as well as the repeated OCT, which are best done by ophthalmological colleagues. Thank you.
Thank you. Thank you so much, Dr. Balaji, for setting up the dais for IIH management. And we move on to the next speaker, Dr. Vijay Sundar, who is going to allude more on the CSF diversion techniques. Dr. Sundar is an established neurosurgical oncologist, and his areas of interest are neurosurgical oncology. And thank you so much. Please do give us the talk on CSF diversion. When, why, how?
Thank you, ma'am. Thank you for the kind introduction. Once again, on behalf of the organizing team, we welcome everyone. Thank you all for taking interest in this CME. We're trying to put together multiple specialties and see how it works. By your response, I would say it works very well. And similar to what my talk is, IIH is a multidisciplinary disease. It is managed by many people at the same time. As sir just now said, the primary disease modifying treatment remains weight loss. The situation arises when that cannot happen in a short period of time and when CSF diversion is acutely needed. So we'll just discuss only that. So I will not discuss about IIS. It's already been explained very well by sir. Moving on. So when CSF diversion, when should we be considered? So one is they're already on medical management or having stopped whatever was the offending drug, but the symptoms are worsening. The causative factor, primarily weight reduction, is not possible in a short span of time that the symptoms are worsening. And the one advantage is, compared to some of the other procedures I'll show you, CSF diversion procedures are more repeatable by many levels of expertise across centers. So now what would we consider for this? Why should we consider this? The basic old Monro-Kelly doctrine. We have to reduce one component that is inside the cranium, and the easiest one to reduce is the CSF. So this remains the option of treatment when there is a diffuse increase in the pressure, but we can reduce only one of these components, that is CSF. How do we do this? One of the earlier procedures was subtemporal decompression. This is the post-op image of a subtemporal decompression. This was said to lower the intracranial pressure, and it worked especially well. It is said to be relevant even now in cases of slit ventricle syndrome, where we have exhausted all the pressure options in the shunts. But this is not actual CSF diversion. So there are only two procedures by which we do CSF diversion. One is lumboperitoneal or a ventriculoperitoneal shunt. Lumboperitoneal shunt is considered safer because we are not handling the brain. We are away from that. We are in the thecal space. The problem being is that it is often done in a patient who is, because of IH, the patients are obese. It is technically slightly nagging procedure in that you have to insert a catheter in the lumbar space, tunnel it subcutaneously, bring it anteriorly up to the peritoneum and put it into the peritoneal space, all in a sterile way. So the disadvantage is the technically demanding, especially if there are obese patients. The workhorse of IH management CSF diversion remains ventriculoperitoneal shunt. To put it simply, a catheter is inserted in the lateral ventricle of the brain, tunneled subcutaneously and inserted into the abdominal cavity, making sure it is in the peritoneal cavity. The advantages is there's less chances of blockage at the proximal end, which is something that happens more often with lumboperitoneal shunt because of the higher protein density of the CSF with the thecal space. The disadvantages is, yes, there is some amount of brain handling, although it is very minimal, but yes, the catheter does go through the brain parenchyma in a blind fashion. Now, whatever shunt we choose to do, it has components. The components are a proximal catheter, which will start draining the CSF, a central valve, and a distal catheter. These are the three major components. The proximal catheter can have multiple holes, can have a single hole. The distal catheter similarly can have slits or have a central hole, depending on the manufacturers of the components. The types of valve is where the huge variation comes. There are n number of valves, and broadly they're divided as pressure fixed valves, flow regulated valves, or programmable pressure valves. So almost all of the programmable valves that we use in day-to-day practice are programmable pressure valves. I'll show you about that. So these programmable valves, common companies such as Medke, Medtronic, and so on, the valve is something which can be programmed at a later date, even after the shunt has been placed inside. How does this help us? Because IAH is a slightly dynamic disease in that we are not absolutely sure that this is the pressure that will remain forever. So it might need a reduction or an increase of the valve pressure, which will regulate the amount of CSF that gets across. And these programming can be done purely by the placing a device on the skin on a post-operative patient. The valve inside has a magnetic component which aligns with the magnetic component which you place on the skin, and then you set the pressure and confirm the pressure. The one small disadvantage is if the patient undergoes an MRI, the pressure regulation has to be checked. Although they say that it doesn't change with the MRI, but it has to be checked and repositioned again. So to finish, when persistent symptoms or when immediate intervention, especially in the case of vision acuity being threatened, is needed. Why is it done? The concept is we are releasing pressure from the brain. How do we do it? Lumboperitoneal and ventriculoperitoneal are options. Almost all of these are done by ventriculoperitoneal shunts with a programmable valve. Now, most often the doubt that happens is how do we actually get a tube from the brain to the abdomen? So we have just put in a slide of showing the tunneling. If you see here, that is the cursor is not there. So that end is the head. There's a small incision. There's a stellate that is inside. Okay, that is the cranial end. That is the ventricular catheter. We have not. This is the junction just before the wall, and you see that there's a tunneling done subcutaneously, and it is brought down where we have already opened the peritoneum. I just put this slide because for many people that is the basic doubt as how does the catheter get from above to down. So thank you once again for all of you for joining us in this initiative. Welcome. Thank you.
Thank you, sir. May now call upon the next speaker, Dr. Ambika Selvakumar. She's going to speak on IAHT, when to consider ONSF. Dr. Ambika is a senior consultant neuro ophthalmology at Sankar Nethralaya, and she's the vice president of the Indian Neuro Ophthalmology Society. Her interests include optic neuritis, demyelination, IIH, and neuroimaging. Over to you, ma'am.
No. Dr. Suhasini copied. Take it back.
Go back.
You want my pen drive?
Okay, there is some technical glitch. Maybe we can move on to the next speaker, Dr. Sabarish. Dr. Sabarish is going to speak on the endovascular management and imaging of papillary edema in IIHT. He's an associate professor at the Department of Neuroradiology and Intervention Radiology at Sri Ramchandra Institute of Higher Education. He's also a part-time consultant at MGM Healthcare. He's about 30 plus peer-reviewed publications, and his area of interest include advanced neuroimaging, endovascular management of cerebrovascular disorders, AVM, ICAD, acute stroke interventions. Over to you, Dr. Sabarish.
I thank outside. I thank Dr. Aarti ma'am and Rupi sir and the organizing team for this opportunity. I won't go for this pathophysiology to diagnose IH in a. We need to satisfy the papillary edema, elevated opening pressure, and positive neuroimaging. In a positive neuroimaging, we need to have three positive signs to clear the neuroimaging positive finding. So when IH intracranial pressure is increased, it reflected on the four areas until in the orbit and over the sella, posteriorly over the tradural venous sinus and over the skull base. So imaging we all see in these areas only. In zone 1 in the orbit, we will see that predominant positive finding will be prominent perioptic CSS spaces, that is optic nerve sheath distension. In MRI, initially we usually will see 3 mm posterior to the eye globe, and we will see if it is more than 6 mm, it is positive, or perioptic space is more than 2 mm, it is considered positive. Then because of the raised pressure, there will be tortuous optic nerve sheath complex, and it will reflect over the eye globe, which will cause the posterior scleral flattening. And the most specific sign is when the optic nerve head over protrudes, and that is the most specific sign. Then other signs are tortuosity of the optic nerve sheath complex. It can be vertical and horizontal. Horizontal is more specific. So it is showing the vertical and horizontal tortuosity. Then over the sella, we will see that the CSF is protruding into the sella and causing the flattening of the pituitary. If normally the pituitary height is more than 4 mm, if it is less than 3 mm, it is considered partial. And when it is completely flattened, it is partial or complete empty cellular syndrome. We need to carefully rule out other causes when the isolated empty cella is there. And so zone 3, where the dural venous sinus stenosis. So multiple theories are there. It can be cause or it can be effective, effect. So when there is when we are seeing the stenosis, if it is smooth, mostly it can be because of the functional cause, like secondary to the raised ICP. And the other one is intrinsically also we can see sometimes filling defect, arachnoid septations, granulations and all. So though if those are there, that will be more significant and it needs to be reported in the findings. So some centers prefer doing MRI before and after to see that reversibility and planning for some procedures. Another way of, instead of subjective assessment, objective way compared to that of the superior sagittal sinus we can mention. So then zone 4, where we can see that skull base foraminal extension like Meckel cave ballooning. And it can be again other oculomotor nerve cistern and other cisternal spaces. So these are the uncommon findings where that arachnoid pits are happening over the middle cranial fossa, or it can be the prominent enlarged arachnoid granulation or herniation of the brain into the arachnoid granulation. Sometimes because of the chronic IH weakening of the skull foraminal areas, and it can lead to pseudomeningocele formation. The other thing is rarely it can develop into cervical radiculopathy secondary to the enlarged perineural spaces. So this one case with spontaneous CS of rhinorrhea, where we can see that leak site in the right crista cali, and there is also from other features of IH features are there. So non-invasive way of assessing is B-scan ultrasound also. So out of the 3, if it is satisfied, is more than 93.5% specificity to the diagnosis of the imaging criteria. So in a pediatric, the cutoff is slightly more for the pressure measurement. So in a pediatric age group, the most sensitive sign is the prominent perioptic spaces. And the other thing is the recently described entity is a prominent oculomotor nerve system, where it is lateral to the cavernous sinus. We can see that prominence of the oculomotor nerve system. So it can be used. So in the pediatric age group, prominent perioptic spaces is the most common finding, and if venous stenosis there, that is more specific. But oculomotor nerve system dilatation also can be included when we are reviewing. So we need to exclude other causes also, like this case of IH initially managed, but later presented severe headache, and repeat imaging we can see superficial siderosis, and spine imaging showed myxopapillary ependymoma. So in a primary IH and secondary IH, the both papillary edema, elevated ICP signs will be there, but primary IH, there will be optic nerve head sheath protrusion, and posterior globe flattening will be more prominent. So coming onto the endovascular management of IH, so we will choose the patient primarily when they are failure to the medical management or refractory to the medical therapy. The other situation are fulminant IH. So initially we will do transvenous pressure gradient measurement. So it will be done usually under by anesthesia. So we will be doing a femoral arterial axis and the venous axis. Arterial axis to look for the stenosis, and venous axis to access the venous roadmap. So this one case we can see the medically refractory IH, where we can see the right transverse sigmoid sinus junction stenosis. So what we will do is initially we will do arterial side run, and we will take the roadmap in the venous phase, and we will access through the femoral vein, then jugular vein, then go into the sigmoid sinus, transverse sinus, and into the superior sagittal sinus. So we will connect that catheter with the pressure measuring diaphragm, and we will make the venous setting. So here we can see that it is in the superior sagittal sinus. Here it is in the IJV. So serially we will measure the pressure measurement. So in this case, the proximal to the stenosis, that is 16, and distal is 5. So pressure gradient is more than 8. We will take as a cutoff. So we will usually do the stenting in a later setting at the separate from the pressure gradient measurement. It will be done under the GA, but in this case, we will take the direct jugular axis for the stenting. I am not going into the technical hardware details, but what we'll do is we'll do balloon dilatation of the stenotic site, and we'll place the stent. So post stenting also we can see that prior and post stenting, we can see that gradient is significantly reduced after the post stenting. So here the bilateral stenosis case, similarly we have done and stenting. Here also we can see that gradient is more than 8 on both sides. Here we have done angioplasty on both sides and placed the stent. So post we will do the ophthalmological here in this patient showed a significant improvement. So we will continue antiplatelet for the 6 months, and continue Dimax for the 3 months, and follow up a venogram to see the resolution. So these are all the other CSF rhinorrhea case. Similarly, we have done after the repair of the leak site. Another one condition is fulminant IH, where we can do emergent stenting. So complication wise, there is a immediate post procedure. There will be puncture site complication, or it can be post stenting headache related to the dural stretch. Major is subdural hemorrhage or venous sinus thrombosis. So I will come on to the comparative efficacy compared to that optic nerve sheath fenestration and CSS stenting. And venous sinus stenting showed a similar improvement in the findings, with along with that decreased complication rate. Thank you.
Thank you, Dr. Sabrish. May I now call upon Dr. Ambika to speak on when to consider ONSF in IIHT.
Good morning, everyone. First of all, let me thank the organizers for this opportunity. I think even my technical glitch was good because now it is opened up not only primary IIH, we also saw an overview of the secondary intracranial hypertension, because we are more concerned about the vision loss in an IIH, because that's going to be detrimental, and that is the key in the management other than headache and a PT treatment. So we'll move on to the classical way how we do a sheath fenestration. So conventionally we do, So this is the place where we are more concerned about. Is the pointer working? Okay, fine. So immediately behind the globe, 1 centimeter is the site where we plan for the sheath fenestration. And we incise the optic nerve sheath, or we make a window to that. Our key aim is to preserve the vision, because we may have patients who are losing vision in front of us. Within 3 weeks, 4 weeks, they can become no perception of light. So that is the case of IIH, what we call as an IIH mimics. Because in our country, I think we have a very less propensity of patients who are coming with the classical Dandy's criteria, obese, overweight. Yes, they do occur. But we have a lot of patients who are not obese, young females who may walk in with critically dropped vision presenting, and they may come with an IIH diagnosis. So we have to be very skeptical in putting a tag of IIH for men, non-obese females. You have to be very cautious, because these are the mimics which can lose vision fast. So these are the indications conventionally. When there is a raised CSF pressure, there's an axoplasmic stasis, papilledema. When there is a rapidly progressive drop of vision or visual fields, when it is medically refractive, even on maximum medication, you continue to have the symptomatology and the vision loss. And when there is an asymmetric papilledema, and when there are an add-on procedures, I think we should come to a conclusion, that neurosurgeons and the ophthalmologists, that if there is a drop in vision in spite of maximum medical therapy, in spite of a shunting procedure, we have to opt for a sheath fenestration, because other than the CSF pressure drops with the shunt, you remember that optic nerve heads do have septae. So they behave like compartment syndromes. The pocketed CSF fluids are sitting around the optic nerve is going to continue to cause an axoplasmic stasis and a progressive vision loss. So we don't have time over there. So time is vision in a fulminant IIH. So this is a very nice photograph algorithm. So remember that fulminant IIH is the condition which we are more worried about, because that is going to cause a vision loss within 3 to 4 weeks. A patient walking in with 6/6 can become no perception of light in front of your eyes. We don't have time for weight loss. We don't have time for Diamox to kick in. So sheath fenestration does work in addition to the other protocols. So when do you want to ask for sheath fenestration? I think the whole world wants to know when you plan fenestration, when you plan shunt. There's no doubt about it. If a patient is sitting in front of you, losing a progressively vision, first thing, as an ophthalmologist, I may think of a sheath fenestration. Yes, I do agree that we have wonderful expertise of neurologists and neurosurgeons available around us, but consider a sheath fenestration if there is going to be a progressive visual decline. And if you're going to make a diagnosis of fulminant IIH, please do consider a sheath fenestration as an add-on procedure to the VP shunt, what you plan for these. And these are the pros and cons of both these procedures. Yes, in a sheath fenestration, you need a clinical expertise. and it may require secondary CSF diversion procedures, and it also improves the optic nerve functions. We need a close monitoring of optic nerve functions, whatever the type of treatment modalities we follow. We have to closely follow the vision, color vision, visual fields, and OCT. Because if there is a progressive decline after the shunting or a sheath fenestration, we may have to go on for the next causes for the drop in vision. So I'm going to take two case examples like that, what we have managed in our place, both of them being referred for sheath fenestration. One we did, one we did not. So the first case is about a 57-year-old male. He came with a progressive drop in vision. You can see here, can I use a pointer, please? This? Okay. See, you can see this right eye is already lost and he has got an hand movements vision in the right eye. Okay. So he's post CSF procedure and you're going to see a disc edema over here with a critically significant disc edema and a vision is 624. So now the visual field is advancedly lost. Still the CSF pressure is elevated. He's already post shunted. So now we planned for a sheath fenestration for him for the left eye. And the vision after 1 month was 618, and you can see that there is a visible reduction of the disc edema. And I will show you the clearing of the visual fields. This is 2 months follow-up. And remember in IIH, it is going to be the central vision to lose last. So you will have a peripheral caving in fields. So there's a significant improvement by 7 months. And this is the OCT. And this is RNFL, which showed a gross elevation in the initial phase. And that's that. So anything red is bad in OCT, to be short. So the right is already bad and the left is slightly getting better. So this is the second case. In fact, she was a ENT postgraduate who was referred to me from one of the senior neurologists in down south. He said that she started developing a stomach flu after our unit party. And that's the key history what she gave me. And she was diagnosed as IIH. She was having she was already having a diamox, topiramate, headache and all. But she said that I'm losing vision drop almost 20 days. So the vision in the right eye was 612 and that of the left eye was normal. And you can see this is a significant disc edema. Already pallor has set in the right eye. And I had to keep her in a close follow-up. And the visual fields also is caving in. There's a significant ganglion cell loss as well as. But she refused for any surgical procedure. She said that she was on 500 diamox when I saw her. So she agreed to escalate the diamox and come for a close follow-ups. And this is the result after 3 weeks of increasing the diamox. So after escalating the diamox, there was a significant reduction of the disc edema as well as the visual field. And that of the 3 months follow-up showed complete clearing of the disc edema. Here we did not take for a sheath fenestration. All you wanted is to just pep up the amount of diamox what she was supposed to be. So this is a good recovery of the disc edema without a sheath fenestration. So you have to choose your patient wisely, which one to fenestrate and which one to watch out. So these are the literature reports. I think you can just flip on to the literatures. Everything showing that sheath fenestration as well as the shunting procedures do have a significant visual recovery. Depends on the local expertise what is available within. And as you had seen, the earlier speaker has told that, yes, there is a role of venous sinus stenting, but you maybe have to be very watchful if you're planning sheath fenestration because they may put them on anticoagulants. So plan your sheath fenestration ahead and then ask for the stenting subsequently. These are the various modalities how we land on the optic nerve. And let me try whether the video plays. Just play the video. So this is the medial transconjunctival approach what we use in our setup. We do a peritomy, tag the medial rectus muscle, disinsert that from the attachment. Just go to the medial stub, which is attached to the globe, take a baseball suture, retract the globe, identify the optic nerve. I'm having so many stuff in my hand. You can see that's the optic nerve, the glistening one. We are nicking with a MVR blade. And now you will see a clear gush of fluid. We are making a window over there. And that's the egress of CSF, which will immediately relieve the pressure on the optic nerve. So there are definite advantages and disadvantages for any procedure, starting from conjunctival hemorrhage to diplopia to proptosis to even globe perforation. So we have to be very watchful about the amount of complications which are involved. And at the same time, we have to be very careful when there are associated CNS infections, anticoagulants, and if there is a mild to moderate vision loss, please do not overzealously adopt for surgical interventions. We still have time. And to conclude, it's a safe and effective procedure. Medial transconjunctival approaches are having a smooth access to the optic nerve, and bilateral edema can have a unilateral sheath fenestration, yet have an improvement in the fellow eye. And always, improvement and stabilization of the vision is the key management of an IIH, and exclude the IIH mimics. Thank you so much.
Thank you, Dr. Ambika, for that excellent talk. May now call upon the next speaker, Dr. Saumini. Medical management of non-IIH pathology. Dr. Saumini is a senior assistant professor, Department of Neurology at Stanley Medical College and Hospital. Her areas of interest include neuroimmunology and neuromuscular disease. She has multiple publications and original articles. Over to you, Dr. Saumini.
Very good morning to all of you. I thank the organizing team of the conference for giving me this opportunity to talk on medical management of non-IH pathology. So what do we mean by non-IH pathology is all the secondary causes of intracranial hypertension. So as we know, already we had discussed optic disc edema due to raised intracranial pressure is what we call as papilledema, and so we are not going to discuss the other causes of disc edema without raised intracranial pressure. So the one point which I would like to emphasize is headache with papilledema is not always diagnosis of exclusion. Modified Dante criteria requires papilledema, normal imaging, normal CSF composition, and elevated opening pressure with no identifiable secondary cause. Underline that, no identifiable secondary cause. So there's a high risk of misclassification. So in case a patient with secondary cause of intracranial hypertension is treated as IH, it delays the definitive therapy, and like, for example, in anticoagulation in CVT, antibiotics in meningitis, and so on. And this risks irreversible visual loss or sometimes neurological deterioration and death. So the clues that point away from IH will always have to be on the watch out for atypical demographic features, subacute onset, fever, associated systemic illnesses, focal neurologic deficits, seizures if present, abnormal neuroimaging features, abnormal CSF analysis findings, or some known precipitating factors which are present in the patient. Always will have to be on the watch out. So the common causes of, common secondary cause of intracranial hypertension will be CVT, CNS infections as far as primary medical conditions are concerned. So there are a whole lot of surgical conditions, dural arteriovenous fistula, intracranial tumors, hydrocephalitis, traumatic brain injuries, and so on. The rarer causes, there are umpteen number of secondary causes of intracranial hypertension. I'm not going to dwell on each one of them, but just we'll have to remember that the whole lot of drugs which are said to cause intracranial hypertension, actually, technically speaking, they don't cause IH. It is drug-induced intracranial hypertension. That's also should be classified under secondary cause of intracranial hypertension. And then failure of the kidney to function properly, liver to function properly, OSA, severe anemia and polycythemia, which can increase the viscosity of the blood and hence cause cerebral venous sinus thrombosis, GBS, whole lot of infections and other systemic diseases which can cause intracranial hypertension. So the general medical principles as diagnostic modalities, we primarily use imaging, neuroimaging, followed by CSF analysis. And then management-wise, it should be the control of the intracranial pressure in general, as well as treat the underlying etiology as far as the secondary causes of intracranial hypertension is concerned. And then on follow-up, always monitor the visual fields, visual acuity, and it's a multidisciplinary management, like as in this conference, it's a multidisciplinary management by neurologists, ophthalmologists, neurosurgeons, and radiologists. So a CVT is the most commonly encountered secondary cause of intracranial hypertension. So the diagnostic workup, MR venography or CT venography, it will confirm the sinus occlusion, do a thrombophilia screening of all the causes which could be a cause for the CVT, identify the precipitating factors of the cerebral venous sinus thrombosis. And as far as management, medical management is concerned, the first line, as we all know, is therapeutic anticoagulation with either low molecular weight heparin or unfractionated heparin. And this is given for a period of 5 to 7 days. Even with hemorrhage in the hemorrhagic influx, we follow the same. And transition to oral anticoagulants, either warfarin or direct oral anticoagulants. So as of now, there is more evidence and proof for warfarin or acetrom as a therapy, vitamin K antagonist, for 3 to 12 months, depending on whether it is provoked or unprovoked. So usually when there is a strong provoking factor for the cerebral venous sinus thrombosis, we give for 3 to 6 months. When it's an unprovoked thing, we usually extend the therapy for 6 to 12 months. And when there is a proper thrombophilic condition underlying, it's usually indefinite continuation of the oral anticoagulants. So acetazolamide here works as an adjunctive therapy for symptomatic intracranial pressure elevation, so to reduce the ICP, and treat seizures in case seizures are present with antiepileptics. And endovascular thrombectomy or decompressive craniectomy is reserved for special cases where there is clinical deterioration. So this patient has been admitted currently in Stanley Medical College. We are able to see the superior sagittal sinus thrombosis as well as the MR venogram, which almost shows absence of filling in the cerebral venous sinuses, mainly the superior sagittal sinus as well as bilateral transverse sinus. The flare section showing the thrombosis. And this is another patient who has also been admitted with a similar condition now with superior sagittal sinus thrombosis. So again, CVT patients may go on to develop dural arteriovenous fistula. So CVT with the dural arteriovenous fistula, what do we do there? Again, start therapeutic anticoagulation promptly, typically with either LMWH or IV heparin. Anticoagulation is part of standard CVT care, and it is not withheld just because a patient has secondary dural arteriovenous fistula. So control intracranial pressure and control seizures if present. Acetazolamide here again can be used for the raised intracranial pressure along with the anticoagulation. So we have to obtain CT angiogram or DSA when we have to delineate a better definition of the anatomy of the DAF to be obtained, and consider endovascular embolization or surgery for the DAF if there is significant cortical venous reflux, if there is hemorrhage, if there is progressive neurologic deficits or persistent symptomatic shunt. So if the fistula is very small, quiet, then we may go ahead with anticoagulation and follow-up. So we'll also have to remember that CVT causes secondary DAF, but also DAF, presence of DAF also can contribute to venous thrombosis as a secondary phenomenon. So here treatment of only the thrombus may be insufficient, and surgical management may be required if the fistula remains high risk. So when there is a dural arteriovenous fistula without CVT, this also can cause raised ICH because of the venous hypertension. So confirm the presence of or absence of cortical venous reflux, and then if symptomatic, observe and follow up the patient. If asymptomatic, if the patient is very symptomatic, progressing rapidly, then we may have to go on with surgical therapy. So a whole lot of CNS infections can cause raised intracranial pressure as a secondary cause. So if it's pyogenic, you treat with antibiotics, viral, antivirals. If it is TB meningitis, is the most common subacute to chronic meningitic cause causing secondary intracranial hypertension. Always we'll have to be on the watch out for TB meningitis as a secondary cause. Fungal meningitis, antifungal therapy. Steroids here forms an important treatment modality in addition to the definitive treatment with antibiotics, ATT, etc. Anti-epileptic drugs, SOS, and management of intracranial pressure. So infectious inflammatory causes, as I told, with IV antibiotics when it's pyogenic, ceftriaxone, vancomycin, plus or minus ampicillin as the condition warrants. And here do not delay the treatment for lumbar puncture or imaging results. Adjunctive dexamethasone, acyclovir, acetazolamide, and ATT or cryptococcal causes, ATT in TBM and fungal meningitis. If it is due to cryptococcal, then therapeutic lumbar punctures form an important line for control of intracranial intracranial pressure, of course, along with antifungal therapy. And if it is CNS vasculitis or some inflammatory cause like sarcoidosis causing raised ICP, then the treatment relies mainly on high-dose corticosteroids and other steroid-sparing agents like immunosuppressants. Cyclophosphamide considered for very severe CNS vasculitis, and MRI brain spine with contrast and CSF analysis confirms the disease. So there is a whole lot of drugs which I told which causes intracranial hypertension. Here is just stopping the causative agent and using acetazolamide as adjunctive therapy. So all the endocrine and metabolic causes like Addison's hypoparathyroidism and hypothyroidism OSA treat symptomatically with hormone replacements. And the intracranial tumors, hydrocephalus, dexamethasone and antiepileptics are mainly used as a bridging therapy. Mainly it rests with surgical management. So the general management of ICP, we are all aware the ABCs and then followed by mannitol, osmotherapy with mannitol or hypertonic saline, and steroids in selected cases. Acetazolamide and topiramate, of course, we are very well aware. Monitoring in the follow-up will be visual acuity, fields, color vision, OCT, fundus photographs, and also look out for involvement of other cranial nerves during the follow-up. So as a summary, this last slide, I just want to emphasize that after confirming papillary edema, neuroimaging followed by CSF analysis, and then treat the etiology appropriately. Adjunctive intracranial pressure control with the whole lot of osmotherapeutic drugs, acetazolamide, steroids when required, and always monitor the vision with serial visual field monitoring OCTs, and then escalate to surgical management if the vision is deteriorating or the neurological condition is deteriorating. So always remember non-IAH causes of raised ICP because they share similar features. Neuroimaging and CSF analysis should be done to, and there should always be a search for the secondary causes, and monitoring of vision with a multidisciplinary team improves the prognosis in these cases. Thank you. Thank you very much.
Thank you, Dr. Saumani. Now for the last talk of the session, I invite my dear friend, Dr. Aarti Deepesh. She's going to speak on imaging in CVT and endovascular management of EAVF. She's finished her MD and DM and is trained at NIMHANS in advanced neuroimaging and neurointerventions. And her areas of interest include tumor imaging, radiogenomics, acute stroke interventions. Over to you, Aarti.
Thank you, Murli. Good morning, everyone, and we welcome you once again for the CME, and very happy to see you all. So my topic is imaging in CVT and endovascular management of dural arteriovenous fistula. The previous speaker has made my life a little bit easy. So she has nicely set in the tone of what is the connection between the CVT and the dural arteriovenous fistula. So CVT, when the venous sinus is thrombosed, it acts as a trigger for the development of DAVF. So there is angiogenic molecules which are secreted, and the vasa vasorum starts communicating with the venous plexus, and then it opens into the sinus. And over a period of time, if there is no recanalization or partial recanalization, so there will be reflex of blood instead of a forward flow in the sinus. It starts reflexing back into the cortical veins, and that's how a dural arteriovenous fistula is formed. Once there is complete recanalization, even though these communications are there, they might disappear on a long run. Okay, so it is dural artery. CVT is very common. I think all of us know about CVT, but DAVF is grossly underdiagnosed. So there should be a high degree of clinical suspicion, and we should know what kind of imaging modality should be requested to pick up a dural arteriovenous fistula. Though these sound very complex, these are potentially treatable conditions. If left untreated, they can have devastating consequences in the form of an intracerebral hemorrhage. So when the clinical details we've already seen, so the red flags in a patient is when there is severe progressive headache, worsening headache, when lying flat or coughing, papillary edema, visual disturbances, atypical stroke patterns. So these are the patients where you will suspect the CVT. And the first thing you will ask is a CT brain, most commonly asked for. So here you can see the hyperdense superior sagittal sinus. This is a plain CT brain. This is not a contra CT brain. And you can see the hyperdense superior sagittal sinus, so which in turn has caused an hemorrhagic venous infarct in the right frontal lobe. So this is a typical presentation of an CVT where the patient most likely will give you a relevant history. They might already be known for a thrombotic disorder, or usual history. Another history is dehydration and alcoholics, and also people who run marathons and next day they come with severe headache. So this is an MR equivalent. You can see the loss of normal flow void within the superior sagittal sinus. So normally the blood vessel should appear black in MRI in all the sequences. So this, you see that the entire superior sagittal sinus is appearing white, which we call as loss of normal flow void. You can see in the axial flare images, even the adjacent cortical veins are not showing any flow. And you can see the venous edema, early venous edema, it is there. And in T1 weighted images, the sinus is appearing hyperintense. And the MRV images, sagittal and coronal images, there is no superior sagittal sinus at all. And the deep venous system and the transverse sigmoid appears okay. So in addition to it, so you can see the features of raised ICT, which is a prominent perioptic nerve spaces and also the empty cella. This is an SWI image. You can see that there is a congestion of vessels, basically indicating the venous outflow of the brain is impaired, and hence there is stasis within the brain. So this is another case. So there can be causes, secondary causes to CVT, which is also apparent in our imaging. So not only we should look for CVT, we should also look what is causing the CVT. So this is a good example of that. So we are seeing absent bilateral transverse and sigmoid sinuses. In the post-contrast image, you can see the linear thrombus filling defect in both the transverse and sigmoid sinuses. And here, what do you see? There is diffuse leptomeningeal enhancement. So this is a case of meningitis, which is resulting in thrombosis of the transverse sigmoid sinuses. This is a post-contrast flare where you can nicely see the enhancement of the basal cisterns. And the cause of it, if you can see, there is a subtle signal change in the left mastoid. So this is left mastoiditis causing meningitis, in turn complicating with the cerebral venous thrombosis. So these findings also, we should have a very keen eye on finding the source for CVT as well. Yeah, so beware of this. Now that I've shown you filling defect means thrombus. So when you see well-defined loculated filling defects within the superior sagittal sinus, you also correlate with the T2 weighted images. And these are arachnoid granulations. Sometimes an arachnoid granulation in the transverse sigmoid will cause a narrowing and impede the flow. But generally in this, if you see, there is no restriction to flow, and you don't feel features of elevated ICT in other images. So before labeling this as chronic CVT or CVT, you should also know the normal variations. In this case, it's an arachnoid granulation. The most common thing you will see is a sinus not being visualized or being smaller in caliber. Okay, so this is a hypoplastic sinus. It's an anatomical variant. Always do not interpret the MR venogram in isolation. Go back to your source images, review diffusion T2 SWI, and if there is a doubt and there is a typical history where the patient is presented with headache and altered sensorium and the goal is to rule out, never hesitate asking for a contrast if you're not very sure. Okay. So this is another case where this young patient who's on hormonal therapy for infertility presented with severe headache, a typical history for a CVT. Now, what do you see in the MR venogram? You see that the sinuses are not clearly seen, the superior sagittal sinus and even the transverse sinus. So with this history, which is very typical for having a CVT, we went ahead and did the contrast just to be sure, and there was no filling defect. So this is basically a mild movement which is giving you the appearance, because it makes a significant difference to treat with the anticoagulation. So when in doubt, always ask for contrast. Even if it turns out to be normal, it carries a significant information on how to go forward with the treatment for the patient. So this is another case where you can see that the anterior half of the superior sagittal sinus is not visualized, and you can see a hemorrhagic venous infarct in the right frontal lobe, and many of the sinuses are not seen. But what you see in the post-contrast image, there is a linear filling defect, long segment filling defect in the superior sagittal sinus, which is partially recanalized. But can this explain the acute right frontal bleed that the patient has presented with? So we should look for it. And if you see, there is a tiny blooming cortical vein, right frontal cortical vein. This, in a case of chronic CVT, there is an acute right frontal cortical venous thrombosis, which is causing the acute exacerbation with the right frontal parenchymal hemorrhagic infarct. So also look for these subtle findings. Sometimes you might or might not find this in post-contrast image. SWI is a good sequence to find out cortical venous thrombosis. Yeah, this is another case where bilateral thalami, you have significant hemorrhagic changes, necrotic changes, and you see some subacute blood in the superior vermian space. And what do you see? There is a filling defect or the loss of flow void within the vein of Galen. This is deep venous sinus thrombosis, one of the serious conditions of CVT. It doesn't give you much time because it is basically draining the deep gray matter structures, and patient will be very symptomatic and might be in a coma by the time you already see it. So this is another case where we have seen sinuses can be occluded without any parenchymal change, or there can be edema or can be hemorrhagic infarct. This is another thing where there's extensive white matter change with hemorrhagic infarction. This is a 9-year-old child where basically you don't see any of the superficial venous system except the partial visualization of the right sigmoid sinus. The deep venous system is patent. This child was not responding to systemic anticoagulation. So that takes us to the role of endovascular therapy in acute CVT. So systemic anticoagulation is the first treatment of choice in all the patients. Even when you see an hemorrhagic infarct, systemic anticoagulation is the treatment of choice. And the indications for endovascular thrombectomy is when there is refractoriness to the administration of anticoagulants, or there is a malignant presentation, the patient presents with stupor and coma on presentation itself, or worsening clinical condition in spite of best anticoagulation, more commonly, as I showed you, in a deep venous involvement, or there is contraindications rarely for anticoagulation. There is a active bleeding going on from systemic bleeding going on. Those are the conditions where you selectively, carefully select the case for an endovascular thrombectomy. So you can see in this child, there is complete non-visualization of the superior sagittal sinus. You can see there is partial filling of the right transverse sigmoid, and you can see extreme venous congestion in all these images. So we have three modalities, three choices for doing a thrombectomy. It can be a mechanical thrombectomy, it can be contact aspiration, or it can be local sinus thrombolysis. So this is a case where you have the aspiration and stentive. This is amount of clots retrieved. And this is post-procedure. You can see complete visualization of the superior sagittal sinus. And the patient at 3 months follow-up, you can see all the sinuses opened up. So in carefully selected cases, we can use this. And now for, in this case, you can see there's non-visualization of the posterior aspect of the superior sagittal sinus, congestion of vessels, and partial filling defect in the superior sagittal sinus. But what is alarming is that we know that this is chronic CVT. But very important to look for this hypervascular signals in ASL. That means there is stasis of signal. This is happening within the superior sagittal sinus. And if you carefully look at the source image of TOF angio, you can see that there is some signal within the right transverse sinus. This should raise a high suspicion of dural arteriovenous fistula, and you should proceed with the angiography. So the clinical conditions in a CVT patient, if they complain of a pulse synchronous tinnitus, ocular symptoms, cognitive decline, progressive myelopathy, if it is not fitting into the clinical syndrome of chronic CVT, please image with an MRI, MRV, and contrast, and proceed with the DSA. So the DAVFs are classified by the Borden and the Cognate classification. We usually use the Cognate classification. It is classified from type 1 to type 5, type 1 being the most benign, where there is a forward flow, and type 5 being a perimetrally venous drainage. So type 1 and type 2A you can observe, whereas cortical venous reflex is present from type 2B onwards, and they are aggressive DAVF and they should be treated. So this is the same patient that I showed you the MRI. You can see the fistula in the toricula, with feeders from the dural branch of ICA, middle meningeal artery from both the sides, and also the occipital artery from both the sides. That's the fistula. Now you can see why the ASL showed a hyperperfusion, because there is reflex within the sinus in this image. That is why your ASL picked up that hyperperfusion. Very important to notice in an MRI, otherwise the diagnosis goes missed. It just goes as a chronic CVT, but the most important diagnosis is chronic CVT with DAVF. And this is an aggressive DAVF. And this is another case where there is complete thrombosis of the superior sagittal sinus, extensive venous congestion. You can see the hyperintense sinuses, and you can see the filling defect within the right transverse sinus. And you can see the cluster of vessels. Asymmetry in radiology is important. You can see the cluster of vessels in the sigmoid sinus and the IJV. And you can see in MR angio itself the fistula. And this is a DAC image showing feeders from occipital artery with a forward drainage. But this patient also had a cortical venous reflex. This is cognate type 2A plus B, which will require a endovascular embolization. And the patient also had another type 1 fistula from the anterior falcine artery into the superior sagittal sinus. But here you can see it is a forward flow. This fistula can be observed. So it's another case where you have the right transverse sigmoid sinus fistula. And endovascular treatment is the preferred modality in complex fistulas. So it is more common in the transverse sigmoid junction, followed by the cavernous sinus. So transverse sigmoid is a case where we embolized both the sides with a squid embolic, and we achieved a complete closure of fistula on both the sides. And the patient improved dramatically, and he presented with altered sensorium. He was completely normal by the time he was discharged. So what investigations to order? First start with the plain CT brain. If it raises Any suspicion, don't hesitate to ask for an MRI. And contrast, definitely ask for contrast, because many of the requests that we get outside is MRI with MRV. Many of these chronic CVT cases, it is very confusing if you just interpret an MRV. Always go ahead and give contrast. And once there is a iota of suspicion of dural arteriovenous fistulas, the gold standard is digital subtraction angiography, because it will help the neurointerventionist in planning the treatment, what are the vessels to select, so that to achieve a cure, which is complete embolization. Partial embolization is not good in a DAVF. If we block the vessel proximally, it is going to recruit collaterals and it will be more aggressive, and the patient will present with much more problems. Whenever you're dealing with a DAVF, the only goal is complete embolization and complete cure. And that requires a thorough planning. So the diagnostic approach, if it's a CVT, anticoagulation, patient is improving, continue it. Despite anticoagulation, patient is deteriorating, then you consider options of endovascular, thrombectomy, thrombolysis. And if there is a DAVF, you have to see if it is a low-risk DAVF with a forward flow, then you observe. If it is a high-risk DAVF, there is a high chance of cerebral hemorrhage, and then we should go ahead and offer endovascular management. Thank you.
Thank you, Dr. Arthi, for that extensive cover. I think we come to the end of this session on IHT, and true to the CME, it is a multidisciplinary approach for the treatment. We had the medical management as well as treatment options from the ophthalmologist, the neurosurgeon, as well as the radiologist, and selecting the right treatment for the patient helps in better clinical outcomes. Thank you so much for the opportunity.
Any questions about the sessions? The session is open for discussion now. Anyone has anything to discuss? Sir.
See, the idiopathic intracranial hypertension is very common problem which we face as clinicians day-to-day practice. There is a lot of dilemma in management. So many times we see that most of the time I think patients do recover with medical management, but then the lifestyle modification like obesity, we underestimate. I think that is also equally important. But I just wanted to know, we have 3 different modalities now. If for a paled patient, we can go for a shunt, it's a conventional rule. We can also consider optic nerve sheath fenestration, or we can consider the new modality of endovascular like a stenting. Now, I just wanted to know from the physician, neurophysicians, what exactly would, from your angle, out of these 3 modalities, which you prefer as the first modality? Of course, we know that the shunt is contraindicated in a patient with a DAVF. If you put a shunt in a patient with DAVF, this patient is going to be worsening, and patient can also go for altered sensorium because there will be acute reversal of shunt. So this is only one contraindication which you remember, but then we have 3 divers. Just want to know from physician, what exactly would you prefer out of these 3 modalities?
First and foremost will be any patients will be not going through a knife. Will be the first trial. And between the endovascular management and the CSF shunt, so basically it's whether it is an extrinsic compression or an intrinsic, whether there is more fibrosis into the venous sinus. The extrinsic compression can be diverted by the CSF diversion. Where there are more fibrotic strands, they do not listen, where the venous stenting can be done. And you have the pros and cons of where the venous stenting itself can be an curative procedure. Or the only thing, the patient, whether they need to be on a lifelong single antiplatelet at least, probably a dual antiplatelets for 6 months and a single antiplatelets for lifelong. And depending on that, we select the patients, we tell it to the patients both the advantages and the disadvantages of the endovascular management. And ultimately, the patient has to choose in between. Sir.
So in the obese female
Yes.
who's not married, who's are planning for marriage and then pregnancy, so probably then you will avoid venous sinus stenting. Is it one of the contraindication, or you still consider that?
Still consider as an endovascular management, sir, because the single antiplatelet is not going to affect our pregnancy also. Okay. Yes.
So which case you think that venous sinus stenting may not benefit? You do a manometry.
Yes, especially when once we do the venous pressure manometry and the pressure gradient is less, and when it is less than 8, we do not prefer stenting, sir. In that case, we do more harm than doing good in the patient.
So why do that such cases
Yes.
where we know that there is a the transversinus sigmoid junction stenosis, whether
Yes.
it is artifactual or it is a real stenosis, we never, across the sinus, we always check for the manometry.
Correct,
But why
sir.
do some patients have that difference pressure? Why some patients do not have? Is there any pathophysiology in that sinus intrinsically?
Sir, most of the see, the difference is, I'll tell you, whether it is a birth defect due to the fibrotic strand and it is a significant stenosis, definitely there will be a pressure gradient less than 8. And it is only due to the CS of pressure which is causing an extrinsic compression, and post CS of pressure you don't feel that gradient, which will be again back to the normal size where you don't see the pressure. So in those cases you can select which one to be stented and which one to be the CS of diversion. Okay. Yes.
One simple practical method which we can use is which I am going to tell you. Suppose to differentiate with a functional stenosis or a real stenosis in the do a CSF and repeat the imaging. The CSF pressure is low, the stenosis will disappear. That's a simple bedside technique rather than going for this measuring the pressure gradient. And why can't we do that?
But the pressure gradient is mainly to choose patients who may benefit
For CSF.
for the venous sinus stenting.
Yeah, that's agreed. But to find out whether it's a functional stenosis or not, that's the first step.
Yes, absolutely. But what they claim is even if there is a functional, the stent works.
Yes, sir.
No, we never know. That's a pathophysiology.
There's no indication for stent in that situation. Because the moment the pressure is low, the stenosis will disappear.
Actually, what your doubt was, even when there is a functional case where the venous stenting is done. Yes, sir. Once the venous stenting is done, the pressure goes down. Okay, and in that way also the pathophysiology is corrected. That's why the intervention you have this debate is going on where the stenting should not be done. No, even when the venous stenting is done, the pressure goes down. Once the venous pressure is removed, the pressure goes down and the pathophysiology is corrected.
Yeah.
So it's still a debatable one where there is no concrete evidence where stenting should not be done. The definitive evidence is when the pressure gradient is not more than 8, do not do the stenting. That's all.
So now you are a neurophysician, you are also doing intervention.
Yes, sir.
There may be a conflict of interest. We'll go back to Dr. Balaji. Dr. Balaji is, yeah. So, and medical management, out of the 3 modalities, if you have a patient who has failed medical management, now we have 3, either a shunt or a venous stenting or ONSF. Which would you suggest or which you do?
Sir, before that, sir, I have seen patients losing vision in front of me and try to do some lumbar drain for a short period of time and ended up in doing VP shunt because I couldn't find somebody doing a optic nerve sheath fenestration on an emergency basis. See, patient is losing vision in front of us. And this stenting, I think patient, I don't think they were affordable enough. This happened about a couple of months back. So patient was losing vision in front of it. She was symptomatic only for even less than 2 weeks. From the time of diagnosis, she had a problem with visual acuity and the fields constricting. So the same dilemma we had, and the patient ended up in having a VP shunt. So stenting, I think studies evidences are emerging. I'm not sure whether I'll subject my patient to stenting straight away. Maybe one of the CSF diversion procedures, which we are okay with the people who have done and who have been benefited. That too, even neurosurgeon sir I was talking to Bala sir. Nowadays, the shift is from the LP shunt towards a VP shunt with a neuro navigation if possible. So the answer to your question is a VP shunt.
So I could get from you that in an emergency setting, you would look for a neurosurgeon to do a shunt based on availability. Yeah. So now I'll come to Dr. Ambika. Yeah.
Sir. So given a choice on medical management, again on drugs, would you prefer Dimox, topiramate? And now with the advent of the newer drugs for weight reductions, like Ozempic and Mounjaro? Can we give it in a combination? That is my doubt, sir.
Yes, madam. We have experience with acetazolamide and topiramate. GLP-1 has come. The evidence with GLP-1 is that the reduction in pressure or the improvement in symptoms is not secondary to the endocrine effect of GLP-1. Rather, they have a direct effect on choroid plexus with decrease in CSF secretion. What they have proved is even before the weight reduction, there is a reduction in the CSF pressures with GLP-1 analogs. But I think we need to see that proof of the pudding. We have not seen, at least I have not seen. I think time will tell for GLP-1 analog. Until such time, I think acetazolamide with a good dose. Madam said the patient who was on a lesser dose, then escalated to 1.5 grams, had good recovery of symptoms. We have seen in front of our eyes many such cases. So I think we use acetazolamide and topiramate.
So now, his question was immediate availability of a neurosurgeon to do a shunt and acutely patient losing vision.
Correct.
So what is your experience? We have also done VP shunt, patient still losing vision. We have done optic no sheath fenestration, couple of patients to stabilize the vision. So in an acutely losing vision, what is the efficacy of, you will do a bilateral ONSF or a unilateral and look for improvement, because both sides patient is losing vision acutely.
So it depends. So it depends on the clinical picture what the patient is presenting to us with. If there is a predominant vision drop, bilateral vision drop, and if we see that already LP CSF pressure is high, and if there is a venous sinus problem also, maybe I will look into the options what the patient will look into, because affordability. In our setup, if we ask for a MR veno stenting and all, I need definitely a higher center for the facility. So if the patient is going to have only vision loss, and if there is a high CSF pressure, and I give the choice to the patient whether you can go for a shunting and then you can come back to us also if the pressure is high. And if the pressure gradient is high, then I would also give the choice that you may have more than one procedure required. And if there is a bilateral profound loss in vision, we have instances where we have done bilateral sheath fenestration in the same sitting. But if it's an asymmetrical loss, we always prefer to the eye with more edema or a profound visual loss, depending on the expertise which is available at that moment.
What is the long-term outcome of ONSF, standalone ONSF on visual outcome?
Visual outcome, it depends on whether you're dealing with a primary IIH or an IIH mimic. If it is going to be a secondary intracranial hypertension where already the patient has a fulminant vision loss, generally we have seen if it's a 4+, 5+ presence, already the fields is caved in and it's an optic atrophy stage where you're going for a vision sheath fenestration, you may not get a very great improvement in that eye where we are doing. You may have a recovery in the fellow eye. Many a times we have seen the fellow eye improving very well than the unilateral sheath, which had a optic atrophy at the time of the procedure. So it depends on the timing, the presentation, and the associated tags.
The patient has improved and then subsequently again losing vision. Have you done a redo fenestration?
That chances were very less, thankfully, in our little experience. Probably we may think of if the patient has got only sheath fenestration. If for example, that patient, he had 3 years back a shunt. So probably if I would ask for the neurosurgeon to go and explore whether the shunt is functioning, do we have to do a revision shunt? I may ask for that. And many a times the window what we create, it's sufficient enough. It doesn't fibrose that easily because we make a window as of now. Because if you make a slit, you are definitely going to end up in having a fibrosis. And that's going to happen within a few weeks to months also. And we always monitor the optic nerve functions. You're going to see if the vision loss is the presenting symptom. If there is going to be a headache or a pulsatile tinnitus, then I say then you have to be in the neurology forte and do not come back to us unless vision is affected.
Sir, Rupesh, recently in 2025, there is a trial called River trial which has been published for venous stenting, and there is a new stent also has been designed only for venous stenting. So far, we have been using the off-labeled carotid stent and other stents like open cell stents which has been used. But now they have come up with the venous stenting per se, but it's still not available in India. Probably by 2026 end or 2027, it's coming. In that trial, as you asked, they have around 500 cases where they have selected both the cases of both functional and non-functional, like with the due to compression and fibrotic stents. They have selected both the cases where the outcome has been the same in both the patients where the stenting has been successful, which has been published recently now. Thank you.
The question to Dr. Sabarish, you will consider a unilateral or a bilateral transition stenting?
Hypoplastic means one side only will do, but most of the cases bilateral will do stenting. And another one is we'll stop antiplatelet after 6 months or 1 year. Don't continue lifelong. And we have followed up for 4-5 years on patients, and they didn't show any complications also. And in our experience, what we see is IH along with the visual symptom. If a patient also having tinnitus, then they will show very good response.
Actually, the antiplatelet thing is dual antiplatelet for 6 months and single antiplatelet for 1 year. So all the study says is like antiplatelet at least for 1 year should be given, because the 1 year is the time where it is highly thrombogenic. So usually it is single antiplatelet for 1 year.
See, the selection of case now, it has been changing the past decades. Some 3-4 decades ago, we were doing shunt for almost all the patients who are medically refractory. We did shunt, no doubt about that. At that time, I don't think many ophthalmologists were doing ONSF. In fact, we were doing ONSF because we had already access to a microscope and we were in select patients. We were doing ONSF. Now, as of now, I see that I am not doing shunt many patients. Most of the patients I refer to the ophthalmologist to do ONSF, and they are doing very well. Only if there is a failure of ONSF, in such patients, I do ventriculoperitoneal shunt with usual shunt with the navigation guidance, or sometimes if it is not possible to enter the narrow ventricles, then we do lumboperitoneal shunt always with a programmable valve to prevent over drainage. One thing which we have not discussed and is very much coming up in the West is bariatric surgery. See, the basic etiology is obesity, morbid obesity, the visceral obesity. We say that by diet and other things, it takes several months to reduce the weight. By bariatric surgery, they achieve it in a very short time, and that is one of the. In fact, now there are trials which is comparing bariatric surgery, the stenting with the shunt and ONSF. And if you see the bariatric surgeon, see there are no bariatric surgeon here. If there is a bariatric surgeon, he will fight with you. He said that I will do bariatric and not only take off the eyes or the brain, I will take the whole body care. I am taking care of the whole, correcting the metabolic syndrome of the body, which is going to affect the heart, all the blood vessels, the kidneys, everything will be corrected by the bariatric surgery. So it all, probably after 2 decades, if you conduct one, the bariatric surgery he may be doing that more than any of us.
Bariatric surgery has now drastically come down after the Ozempic. After this Ozempic came, as all the bariatric clinics are shutting down because it has become a very regular drug, like everybody is prescribing, and so I think that is very important point. Weight reduction has to be the key base of funda. Otherwise, whatever we do, it is going to fail. So that is the thing. The other thing which is also there is, we also do transnasal endoscopic optic nerve decompression and then the CS of opening of the fistula. Some centers are doing, we are not doing, but we have done only one patient because for patient are other pathology also. But that is also, but we are unnecessarily introducing infection to a already existing CS of pathology. But there are some centers who do and claim that having better results. For example, somebody who doesn't want any scar, it can be done endoscopically. Endoscopic optic nerve sheath fenestration can also be done. You want to make a?
I'll just make one comment. In the current use of more and more GLP-1s for the management of fitness and all, we have patients who are reporting for fitness who have taken GLPs coming with an ischemic optic neuropathy, because it is very underreported and yet to be seen in our population, because it's quite a known complication in the Western literature. And now with the zeal and weave of all these GLPs, we have to be watchful. Already when we have a papilledema which can go in for an optic neuropathy, we have to be thoughtful in using GLPs.
Is topiramate. I had a couple of patients with topiramate having, pigment dispersion into the angle of the anterior chamber causing glaucoma. So I feel it's better to, evaluate the eye before starting the topiramate.
I think
Thank you, esteemed panelists and delegates. It was a really wonderful session. Still, the debate of surgery versus ONS versus stenting continues. Probably we'll have to choose it on a individual patient basis. Thank you so much. We'll complete this symposium and we'll move on to the next symposium. Before that, I have a small announcement for the postgraduates who are interested in the quiz. Please come and register in the desk. We need us teams of 2, and we prefer interdisciplinary teams rather than people from the same discipline.
Thank you to our respected chairpersons and speakers for conducting an engaging discussion. We shall now proceed to Symposium 4 on compressive lesions of the optic apparatus. May I respectfully invite our chairpersons for this session to kindly come forward and take their seats on the dais. Dr. Devigan, Dr. Mohan Sampath Kumar, Dr. Ravindra Mohan, and Dr. Gopinathan.
May now invite Dr. Kirti Koka to talk about the evaluation of proptosis.
Very good morning to all, and thank you so much for inviting me, an ophthalmologist, to be a part of this Neuro CME. So I'm talking about evaluation of proptosis. So many a time a patient presenting to a neurologist or neurosurgeon also does have proptosis, since the eye is at the junction of the orbit where we are in connection with the brain. So it is very important to know how to evaluate, because evaluation gives a key to diagnosis. Yeah, okay. Sure. Yeah, no problem. So as we all know, proptosis is a forward protrusion of the eye as the presentation gets ready. So there's always a confusion between what is proptosis and what is exophthalmos. So proptosis is basically a passive protrusion, whereas exophthalmos, most people almost always associated with thyroid eye disease, is an active protrusion, which is because of some kind of inflammation in the eye. And then there is dystopia, which is generally going to be a displacement, which is going to be not axial, but a non-axial proptosis, which is going to be dystopia. So it's very important to know these things, because it gives a clue as to where your particular lesion is sitting in the orbit.
Till this presentation is set right, I wish to call Dr. Chidambaranathan, imaging of orbital pathologies.
Updated. Correct. Okay, right. Pointer on the point of laser point. Okay, thank you. Okay. Thank you for the chairperson for the nice introductions. Okay. Today I'm going to make it next slide. Okay, Gopi, thank you very much. No issues.
Okay.
Go ahead, no issues.
Okay.
I am Dr. Chidambaram from Apollo Hospital, Chennai.
Okay.
I'm going to talk about the compressive lesion of the orbit. I think Madam actually going to talk about the proptosis. Okay, doesn't matter. We can have it later also. Okay, imaging. I'm going to use only imaging perspective. Okay, so imaging pairs actually often the lesions are mimic always similar. Sometimes compressive lesion, maybe intraconal or extraconal, or maybe intracanalicular, lesions look almost similar, unless we have proper approach. Okay, so this is more crucial for big diagnosis, particularly as a clinicians and as well, we need about what is the clinical presentation, what is the key imaging finding. So what the imaging finding will be, it is offering towards the diagnosis with the background of the clinical background. So this is so vital. So look at this, two lesions are almost similar with some subtle calcification. But if you see carefully, this will be optic nerve sheath meningiomas. This is like a venous malformation with diplobolity. So like that. So we have to go some approach. So approach to the orbital vascular lesion can be, lesion may be gradual onset with painless, or rapid and painless, and acute very painful lesions, or maybe sometimes lesion may be incidental. So we have to use the first, very lesions are gradual, painless for a pediatric population. In a pediatric population, most commonly will be, you know very about optic nerve gliomas. Optic nerve, it is a part of the invagination of the neural tissue. So it is a neural tissue. Okay, neural tissue. So gliomas start from the, it is the entire optic nerve. So centering on the optic nerve as such. So it starts from the almost like entire orbit of the course. It can involve and the expansion, and the typically very characteristic buckling will be there. So the optic nerve enlargement, centering will be one of the characteristic finding. It can be optic nerve glioma, can be part of the neurofibromatosis, neurofibromatosis 1, can be tortuous or kinked appearance, or maybe sometimes maybe fusiform expansion of the optic nerve in a sporadic type. So these are the typical optic nerve gliomas. So optic nerve glioma can be differentiated, could be differentiated to the optic nerve sheath meningiomas. I'll come to later. So it is basically, it's the primarily involved the optic nerve. So expansion, kinking. Okay, lesion in the adult, very gradual, painless, can be a lacrimal gland mass. Okay, the lacrimal gland mass can be benign or can be malignant. The imaging feature may be always helpful. Always you check with your radiologist, can say that, well, the diffusion restriction or maybe some erosions, and there is a feature of malignant process like infiltrations or maybe necrosis, diffusion restriction. These are all changes. This is a case of lacrimal gland adenoid cystic carcinomas, whereas this is a pleomorphic adenomas. The adenomas and the infiltrated lesions can be differentiated. So in adult gradual lesions can be lacrimal mass or orbital meningiomas. Orbital meningiomas, as I said, it is optic nerve sheath involvement. So it can be, it is actually, there are some few signs. Okay, radiologists must be knowing that the signs are tram-like sign along the nerve sheath, and or maybe a downward sign. You can, as you see the downward sign. So this enhancing optic nerve. So orbital lesion can be around the optic nerve sheath. So optic, you should not mistake as optic nerve pathology primarily. Okay, optic nerve glioma on the other side, there will be fusiform expansion. Optic nerve meningiomas, apart from optic nerve meningioma, you can see the optical wall. So the wall may be intraosseous. That is because the meningeal wrist will be incorporated within the optic, within the bone. So it is optic in the bone. You can get, it is what is called intraosseous meningiomas with the wall thickening and as well as enhancement and sclerosis margin irregularity with the meninges. So this is orbital meningioma, orbital wall meningiomas. Okay. So lesion in the superior orbital fissure can occur. Okay, we can see that here the superior orbital fissure lesions. We have seen our optic nerve along the here superior orbital fissure. Superior orbital fissure lesion can extend from third, fourth, sixth nerve. Okay, or you can see the lesion is actually around the third nerve. You can see the appreciate third nerve clearly here on the right side. So this is lesion arising with the third nerve and the entire course of this along the superior fissure into the intracranial part, and as well as going to the retrobulbar space. So it is nothing but it is a typical enhancing lesion. It's like the third nerve schwannomas. Okay, so similarly, yes, schwannomas can occur in other part. Will be here this example of the lesion in the involvement of the again exactly intracranial part and the retrobulbar and as well as the posterior aspect of the almost paracavernous lesion. So the lesion can be involvement of the and exactly the third, fourth, sixth nerve course. But we have to see carefully. If you see the lesions course, how the extension, you can see the extension along the frontal nerve, along the frontal nerve. It goes along the frontal nerve. So you can make a diagnosis along the course of the lesions. So lesion course along the nerve. So most likely it is a V1. So V1 exactly frontal nerve lesions. So we as radiologists can make a diagnosis, the location and the extent give a clue for make a diagnosis. This is an error. So similarly, superior fissure lesion can involve the areas of that. So the signal intensity, sometimes maybe signal intensity, fat containing lesions. This is a typical of a dermoid can encase them and causing the compression and compressive lesion. A dermoid. So lesions in the extra conal or maybe outside the orbit can occur. Lesion can this lesion may be expanding bony lesions. It can be simple benign osteofibromas with encroachment, or can be a solitary fibrous tumor with a lot of changes that highly vascular lesions like a lesion can producing these changes. So sometimes systemic manifestations. Always as a radiologist or maybe a clinician, you can make a diagnosis based on the other clinical symptomatology. Patient having there's retroperitoneal fibrosis, this patient having already there's bilateral symmetrical masses in the lacrimal gland with extracorneal to intracorneal extension. So the lesion having this xanthogranulomatous infiltration by the Ehrdom's disease of the orbit. Okay. So now coming to the rapid and painless lesion in the pediatric population. Rapid painless lesions always know it will be very quick lesions. Retinoblastomas, the example. Okay, or it could be rhabdomyosarcoma, or these are all highly fast-growing lesions in the pediatric population. Rhabdomyosarcoma, or sometimes LCH also can producing changes of the lesions in the very commonly can occur with the pediatric population. Another one, infantile hemangioma. Infantile hemangioma can have that lobulated and encapsulated mass lesion with intense enhancement, very characteristically involution after 3 to 4 years. Okay. Now, rapid and painless lesions. Painless lesion in the adult, many lesions can be melanomas or lymphoproliferative lesions like lymphoma, metastasis can occur. So this is the example of those lesions can have that with the diffusion restriction. That means it's a lymphoma. Non-diffusion restriction lesion can be a lymphoproliferative lesion of the benign lesion can occur. And this is a patient having that multi-lymphomas, again diffusion restrictions. Or melanomas. Melanomas also can occur intraocular, or it can extend retrobulbar lesions. Okay. So this is a patient having there's no typical bony lesion with there is a lesion extra osseous soft tissue component completely encroaching the orbital apex. It is a prostatic from the prostatic malignancy, prostatic metastasis. Now coming to the acute painful condition. Painful condition may be inflammatory orbital syndrome. It can be varying stages. There is a separate classifications that it can occur retrobulbar space or periorbital soft tissues, or can occur in the along the sclera or involvement of the entire optic nerve sheath involvement. Can or maybe retrobulbar areas anywhere. So anywhere you can get it. So most of the time will be in the diffusion restriction will not be there. So that easy to make diagnosis. Okay. So inflammatory orbital syndrome with differentiate by the lymphoma by doing low ADC value, relatively painless lymphomas, and more often bilateral involvement of the lacrimal gland. Whereas inflammatory condition will be more high ADC and respond to the steroid, but painful conditions. Okay. So incident lesion can occur commonly will be vascular malformation. Can be vascular malformation with the dynamic contrast studies. Can be arterial phase, venous phase, dilated phase enhancement, or veno-lymphatic malformation can fluid level hemorrhagic area due to maybe intralesional bleed. Orbital varices can be diagnosed by dynamic studies with that rapid avid enhancement causing particularly patient having a dynamic contrast. Okay, if you're using dynamic contrast, we have enhancement in the Valsalva maneuver can producing changes in the vascular malformation enlargement. So this patient having dynamic contrast showing vascular malformation with increasing size, so this orbital varices. So summary, the clinical presentation is the key, okay, which is whether painful or painless or acute or gradual or periodic versus adult. Okay, on imaging, the location give a clue important whether the arraching optic nerve or lacrimal gland, extraocular muscle involvement can compress cause that this one. Or bone remodeling in a slow process, hyperosmosis and enhancement pattern and diagnosis. Having said all that, okay, we'll have shared that maybe surgical colleagues there here. Here the patient, last case, the 30-year-old patient having a high-grade tumor in the posterior fossa. This is the posterior fossa tumor having that medulloblastomas, and the patient was operated through the subhospital craniotomy with the excision of the velar approach, that because access the fourth ventricle through the cerebellopontine medullary fissures, because without much of compromise the parenchyma, cerebral parenchyma, biopsy malignant round cell tumor. Okay, but patient developed pain in the orbit after 6 postoperative days. Okay, so the first one is they operated on 21st August, 28th August, and 21st days orbit are normal. So look at the orbits are normal, and this is 6th postoperative patient having pain in the left orbit, right orbit. Okay, pain orbit is essentially normal. And 8th postoperative period, patient having a lot of swelling, edema, and there is ischemic phenomena, and there is a complete area, there is a burst, completely there is some rupture. Okay, so why the panophthalmitis, ischemic optic neuritis, and global rupture? Why this occurs? Okay, this will be nothing but ischemic. There is a dynamic process, a functional element causing compression syndrome. Okay, so this is a compartment syndrome causing of the ischemic phenomena. With there is a so much in the ischemia lead to there is rupture of the and the globe. Okay, so what is the pathophysiology? So pathophysiology is secondary to this ischemic optic neuropathy, later to a progressive prolonged surgery, head dependent position, and increased intraocular pressure leads to the reduction in the perfusion pressure in the orbit and the decreased ocular perfusion. This is resulting in optic ischemia and scleral rupture. So we should know that this typical the dynamic process of the compression also we should be familiar with. Thank you very much for your attention.
Thank you. So like I said, we have a wide variety of tumors which involve the orbit, and as Dr. Chidambaram just showed, there are so many lesions which involve the orbit and spread to the brain. So how do we classify proptosis? So you can classify it based on displacement, the laterality, etiology, onset, age of onset, and pulsation. So I'm going to run through these. So based on displacement, you can have axial. When you say axial, that means there's something within the muscle cone which is just causing a forward protrusion. So most often in adults it is thyroid, but otherwise it can be optic nerve tumors or sometimes a carotid cavernous fistula when you have something in the cavernous sinus or AV malformations. But when you have an eccentric proptosis, that means the eye is going in a particular direction. So these examples are going to be, suppose you have something supratemporal, it's generally a dermoid. If you have something in the supramedial, it's generally a mucocele or a meningocele. Laterally, you can have common in adults are going to be lacrimal gland tumors. Sometimes you can have lesions from the maxillary sinus moving upward, and sometimes schwannomas which are present superiorly. So these are examples of a lesion which is present supramedially. This is a lesion, lacrimal gland lesion, which is causing a down and in displacement of the eyeball. And here you can see the entire eyeball is going up. This is a maxillary sinus carcinoma. Most often you'll see cases which are unilateral proptosis. So if a person is coming to you with a bilateral proptosis, it further narrows down your differentials. Most often it is thyroid eye disease which is inflammatory. Neoplasias are generally lymphomas, leukemias. Structural can be craniosynostosis, and vascular such as CCF. Etiology, there can be inflammatory etiologies. Most often inflammatory patients will have an acute onset. In contrast will be patients with thyroid who generally have a more chronic onset, other than patients who are presenting with dysthyroid optic neuropathy. Vascular lesions like varices or lymphangiomas, the patient can present you with a bleed. So they can also have acute onset. Cystic lesions generally are very chronic. Patients will sometimes not even recognize it until it is causing a disfiguring proptosis. Benign tumors in children, capillary hemangiomas in adults are cavernous, whereas malignant tumors are going to be lacrimal gland tumors and lymphomas, which are the most common in adults, and rhabdomyosarcoma, which is common in children. So based on onset, you have acute, which I said again was infections, inflammations, and sometimes neoplasias, when you're having an acute necrosis inside a tumor, and vascular. Whereas subacute is going to be thyroid and benign tumors. Based on age of presentation, you can again divide your proptosis. Children generally will have capillary hemangiomas, your dermoids, lymphangiomas, gliomas. These are all going to be seen in children. Malignant will be rhabdo and retinoblastomas. Whereas in adults, most commonly thyroid, cavernous hemangiomas, optic nerve sheath meningiomas, followed by which you have your lacrimal gland tumors and lymphomas. You can even classify proptosis based on pulsations. Here, it's very important to differentiate between true pulsations and transmitted pulsations. Okay, so true pulsations are going to be those which are really some pathology which is lying in the arteriovenous region, such as your CCF and your aneurysms. Whereas transmitted pulsation is because there is a defect in the roof, such as your meningocoels and encephaloceles. So it's important to differentiate these. So most important is history. History gives a big clue on what your diagnosis, then local examination, ocular, systemic, investigations, and then you go to imaging. That's how you approach a patient. So history, it's important to ask acute, chronic, whether it's unilateral, bilateral, double vision. Sometimes the patient won't even recognize the proptosis, but he'll give you history of double vision, or he'll give you history of squinting. And aggravating relieving factors. So a person says, when I bend down to lift weights, if it's a young middle-aged man, it gives you a clue that it's a varix. Okay. And then sometimes patients will give you a systemic history of thyroid eye disease. So that gives you hypothyroidism or hyper, which gives you a clue that it's going to be thyroid eye disease. Family history of malignancy is important because many a time patient will not come out with a history of malignancy because that's something they want to keep away. So it's very important to probe into that history. And diabetes, because you can have lesions like mucormycosis, etc., which can involve the orbit, sinuses, brain, which are commonly seen in patients with diabetes. Okay. These I've already completed. So inspection, very important to palpate every case, examine the case, measure the amount of proptosis, lag of ophthalmos, and look for corneal exposure. That's something which is always forgotten, and then the cornea gets compromised. So patients with proptosis, very important to look for lag of ophthalmos and start the patient on some kind of lubricants, motility, and any signs of inflammation. We have something called a Hertel's exophthalmometer, but if that is not available, you want to make sure that the person is actually having a proptosis. You can do these two things, which are called the worm's hole view, which you look from below. You ask the patient to tilt the head back and you look from below. That's called the worm's hole. Or you stand behind the patient and tilt the head and look. That's called the Navziger's test. Otherwise, we have these simple instruments where the most commonly used one is a Hertel's to measure the amount of proptosis. So this is important in when you're following up the patient. You can see follow-up whether the patient is actually improving or not. Palpation to see for compressibility, reducibility, pulsations. You can even auscultate. This is how you elicitate a Valsalva. You generally ask the patient to sit, bend forward, and wait for 30 seconds. And when you look, the patient's eye will be prominent. Here you can see the boy's eye has got displaced upward. If it's an obese patient, can't bend forward, you can just ask them to force blow. That will also elicit a Valsalva. Other than that, it's very important to examine the eye, the anterior posterior segment, because they can have disc edema, they can have choroidal folds. Look for prominent corkscrew vessels, which are seen in CCF patients, color vision, intraocular pressure, the visual fields, and diplopia charting. These all should be done for completion because sometimes you have subtle clues in all these for diagnosis. Also, it's very important to do a complete thorough systemic examination to look for lymph nodes, parotid enlargements, because they can also have systemic associations. So when you come to management of these patients, always remember, yes, the patient is coming with an eye issue, but it's first to save life, then comes sight, then comes cosmesis. That is always the for the way it goes. So treatment can either be an incision or an excision biopsy, followed by chemo, radiation, or steroid treatment based on the etiology. I'm just running through a few cases where treatment trends have changed over time. This is a child who presented with acute proptosis. And when you see imaging, they have the characteristic fluid levels, which is lymphangioma. Earlier days, treatment used to be surgical excision of these lesions, either transorbital or transcranial approach. But now there is a very simple sclerotherapy called bleomycin. We usually do an ultrasound guided bleomycin, so you don't have to have a CT guided or anything of that sort. We just use ultrasound to localize the lesion. We go directly with a needle into the lesion, aspirate the blood and inject bleomycin, and patient does really well. You can see here there's complete resolution of lesion. Minimum range of injections can vary from 1 to 5 or more based on the extent of the lesion. Cavernous hemangioma, These are generally intraconal but can be present in any quadrant. Earlier approaches were through eyelid crease, but we generally use a transconjunctival. This leaves no scar on the patient and the lesion can be completely removed in toto very easily. We generally use a transconjunctival approach for most of the lesions so patient doesn't have a scar. But you can also have certain cavernous hemangiomas which can be dealt differently. So this is a patient who presented with counting fingers, acute drop in vision, and you can see there's a field defect. So this patient had a cavernous hemangioma close to the apex. So such lesions, when you're going to operate them, they have a high risk of vision loss. So this patient was treated with radiation treatment. 500 gray was given in 27 fractions. And you can see that the patient's vision has improved to 6/9. Fields has improved and even the lesion has decreased in size. So this is something which can be considered for these small peanut lesions that we say, which are situated at the orbital apex. This is a patient with glioma. Earlier days treatment was observation. There's a fusiform enlargement, but now patients are doing very well with chemotherapy and older children with radiation. The lesion does not completely disappear, but it stabilizes the lesion and in some cases even decreases the size of the lesion. So it is nowadays we don't follow the concept of observation. We start the children with chemotherapy earlier because we don't want them to come to the stage of vision loss. And most often they're presenting very early in life when you can't really assess their vision other than a VEP which can be done. So we start off with chemotherapy and we have very good results. Coming to optic nerve sheath meningioma, like doctor already said, the classical tram track sign. So from observation, treatments have now shifted to stereotactic radiation treatment. This is a patient who presented with acute drop in vision. Her vision was hand movements, but post radiation, her vision improved to 6/6. She's on 3 years follow-up and doing very well with a stable lesion. Surgical is indicated sometimes. Like this patient presented with an exophytic meningioma. So since it was an exophytic, we treated her with radiation. But however, she had progression of the lesion. So that gave us a doubt whether are we really dealing with a meningioma or something else. So here we went ahead and did a biopsy, which came as transitional grade 1 meningioma. So now patient is on treatment with chemotherapy because we have already given her 50 gray of radiation. So we cannot give her radiation again. And she's stable with chemotherapy. Adenoid cystic carcinomas, they're huge lesions. They can involve the orbit, they can have erosions, they can have transcranial and perineural spreads. So earlier, always we went with the treatment of exentration, but we want to save the eye because many of these patients have 6/6 vision. So this is a patient you can see has a huge lesion sitting in the supralateral part of the orbit. So we did a digital subtraction angiography. The internal carotid as well as the internal maxillary artery was both canalized, and they found that the supply to the tumor was from the internal maxillary artery. So here the patient was treated with intraarterial cisplatin and IV docetaxel. So this is intraarterial chemotherapy, IACC. And you can see here 6 weeks later, the lesion has decreased in size. So because of the decrease in size, we were able to go ahead and do a complete excision rather than doing an exentration, followed by chemotherapy 3 cycles after. And patient is on follow-up for 5 years now, doing well. So intraarterial chemotherapy is possible for patients who have an intact lacrimal artery. Other than that, we also have neoadjuvant chemotherapy to downsize the tumor, followed by complete surgical excision, followed by radiation and chemotherapy. One thing is very important to remember: in the orbit, we cannot have what is called complete surgical excision or surgical clear margins. So most of these patients will receive radiation after complete surgical tumor excision also. This is a case where we always, sometimes we need a neurosurgical guide help in the thing. This is a patient with a schwannoma. We thought it's going to be a routine surgery and nothing is going to happen. But post-surgery, we realized that she had a defect in the roof from which she was having a CSF leak. So this patient was managed. We work with Dr. Suresh Babu and Dr. Vishwaraj. So this Dr. Vishwa gave me instructions on the phone, and I harvested the orbital fat, and then I plugged the defect with orbital fat, placed Surgisil, glue, and sealed the defect. Here I got lucky, I was able to do it myself, but this is a larger lesion which was having a roof defect. And you can see here there's a huge defect in the roof. So these are places where neurosurgeons come into the play for us. And here you can see facial lata and fat being harvested from the thigh. And this was then used to close the defect completely. Sometimes such patients even require a lumbar drain to be placed for allowing the wound to heal completely. So management of these cases, not always by the ophthalmologist. It requires ophthalmologist, ENT, and a neuro team. A pathologist, very important for diagnosis, medical and radiation oncologist for further treatment, and sometimes an ocularist to give prosthesis for better quality of life for the patient. So less invasive alternatives can be globe and vision saving. Very important You have other alternatives, but if you have a doubt, always lean towards surgical interventions. Teamwork makes a dream come true. Thank you.
Next talk by Dr. Ravindra Mohan on surgical management of orbital tumors.
Very good afternoon, dear friends. It's a great privilege to be back to MGM and meeting all the friends. I wish to thank Rupesh and, of course, the management of MGM for having me for this talk. Both Kirti and Dr. Chidambaranathan have made my task very easy, but we'll quickly go over the main features of the orbit which make surgery both exciting, challenging, and risky. The orbit, as we know, is a microcosm which has a variety of tissues, and it's a small space. It's just about 30 ml, and all the activity an orbital surgeon does is within this very limited space. If you look at the anterior posterior extent, it's just less than of the range of about 4 centimeters, and of which the globe occupies almost 6 ml out of the 30 ml. So it occupies the very central part of the orbit. So what are the challenges in orbital surgery? One is limited space, tightly packed with vital structures. There are blood vessels, nerves, muscles. The globe occupies a central position, and all the extraocular muscles are attached to it, so that makes playing around that area quite risky. The vascular supply to the optic nerve and eyeball is tenuous at best and easily disrupted. Of course, a famous Indian scientist only has explored optic nerve blood supply. So Dr. Sohan Singh Hare, we owe a lot to him, and we know that the blood supply to the nerve is very tenuous. So we have to be very careful to prevent catastrophic visual loss. And also things like postoperative edema or a bleed within the closed confines of the orbit can be disastrous with compressive optic neuropathy and acute loss of vision. Now, what are the approaches? Broadly, these are transseptal skin approaches which ophthalmologists generally used in the past, like when I was a trainee. Transconjunctival approaches which Kirti mentioned about and which are almost completely obviated the need for the other approaches. Endoscopic approaches mainly for the medial orbit, also for some of the inferior orbital tumors, and of course the neurosurgical approaches which Dr. Rupesh and his team do. Now, these are basically the approaches: Stallard right, modified Stallard right with a lid crease, a Berkey incision, a medial orbitotomy incisions, like a Lynch incision, and then again incisions which are involving the lid crease with some relaxing incision, a vertical blepharotomy which opens up the lid and exposes the superior orbit, subciliary incisions, and transconjunctival incisions. So we'll quickly go over these. First, coming to the superior orbit, these are for lesions not extending beyond the orbit, because if it goes beyond the orbit, obviously we need the neurosurgeon's help. And a lid crease incision is a beautiful incision because it is hidden within the lid crease, and virtually there is a scar, but it's not cosmetically a blemish. Larger masses may need what I mentioned as a vertical blepharotomy. We cut open the lid into two and enter the superior orbit, remove the tumor, and put the lid back very beautifully. These superior orbital approaches are important for now, of course, superior orbital lesions larger. I think Kirti mentioned about the potential complications of superior orbitotomy. Of course, one has to be very careful. In a multi-specialty hospital where you have neurosurgeons with you, it's easier. But still, it's good to have a combined approach in these cases. And of course, there is some role for navigational guidance. Some of the recent cases we've done superior orbitotomy for involved using navigation. Then comes lateral orbitotomy. This used to be the real big workhorse. This is the kind of surgery that we assisted a lot when we were in training. For lateral orbital tumors, intraconal, apical lesions, provides very good exposure, wide access, but it has limitations. There's a prominent scar. Nobody's going to miss this scar because it's in the most important visually most important part of the face, and often prominent. The scar often becomes prominent. There's a bone flap removal. You have to take a bone flap, remove the bone, get the access, put the bone back. All increases surgical time. And of course, at some points of time, we used to put a drain and all that, and these patients used to walk around the hospital for 4 or 5 days. Now, these are the broad steps of orbitotomy, wherein it's either a lazy S kind of a stellar right incision, a lid crease incision, then getting to the periosteum, retracting the temporalis muscle. So there are many steps involved in this. Then we come to the medial approaches, classically through a frontal ethmoidal incision like a Lynch incision, but again, disadvantages. There's a cutaneous scar, there can be webbing, and of course, risk of injury to the medial canthal tendon or the lacrimal sac. These have almost entirely been replaced by transcaruncular approach. The caruncle is a beautiful part of anatomy, which is extremely easy to access for us ophthalmologists. We are always used to handling conjunctiva and tissues around it. The caruncle provides us with a relatively blood-free access to the medial orbit. So things like orbital decompression and tumors in the medial orbit are very easily accessed with very little bleeding. So avoids a visible scar, preserves the integrity of the MPL, avoids damage to the sac, and provides excellent exposure. Now we come to inferior approaches. There have been many transcutaneous approaches like the subciliary, which was the workhorse for a long time, then infraorbital, and approaches somewhere in between using the relaxed skin tension lines to make sure that the scar is not visible. But in my clinical practice, it has been entirely replaced for at least the last 2 decades with a transconjunctival approach, wherein there is virtually no scar and it can be preseptal or postseptal. So this is a sagittal section to show you what subciliary incision, how it approaches the inferior orbit, versus the transconjunctival incision, which may be preseptal or postseptal, depending on whether you want to approach the bone or the inferior orbital spaces. Coming to transconjunctival approaches, all of these have very low rate of scar-related complications. They have virtually no scar because conjunctiva is tissue which heals like a dream. Most aesthetically pleaseful patients are mighty pleased, and you are also obviously happy. It is combined with the lateral canthotomy or cantholysis or transcaruncular extension. So it is something you can titrate. You can start with small incision. If the tumor is larger, you can extend it without any fear. And so canthotomy, cantholysis, we also call it as the swinging eyelid incision because the eyelid becomes free at the lateral part. There are certain limitations, risk. Apex to the orbital apex is difficult. Approaching the orbital apex is difficult by all methods actually. But neurosurgical approaches, of course, have a benefit there. But the minimally invasive orbital surgery has certain risks and learning curve. So this is what a lateral canthotomy, cantholysis achieves in the sense that the lid can be swung. Now, very quickly about minimally invasive orbital surgery. It has actually revolutionized orbital surgery. Like any other part of the anatomy, chest, abdomen, anywhere, minimally invasive operations have actually caught on very greatly. And the conjunctiva and caruncle offer excellent portals and scarless surgery, much less hospital stay. Most of my patients are off the next day, but case selection is vital. Given a choice, nobody of any age, either sex, wants a scar. So I think that's very important. Surgery is faster and can be performed as a short stay. Now we quickly run through a few pictures. This is the anatomy of the conjunctiva. There's the bulbar, there's the palpebral. And you can see that one can access the transconjunctival approach anywhere, 360 degrees. These are some of the very initial pictures. A girl with a big inferior orbital tumor, no scar. These are all pictures taken on day 1 post-surgery. Large tumors. This is a very large tumor which has been removed through a transconjunctival approach. This is the appearance at the end of surgery. Another large tumor. Look at how big it is. And it's amazing how it comes out through a small incision relatively, displacing the nerve. And this is the transconjunctival approach. This is another person who was an army person, and he would have definitely been unfit to continue with his work if there was a visible scar. And this is the naphzygous view, which Kirti mentioned about. I just take a couple of minutes to round off. And this is the large tumor displacing the nerve. One can see how close it is to the nerve and how challenging the surgery is. And this is the tumor at the end of it. This is the appearance at the end of surgery. And we just gently reposition the conjunctiva back. And this is the patient a month after surgery, perfectly fine and happy. Now, I'll end with a small case, which was a prenatal diagnosis of an orbital tumor. This child's mother, when she went for a pregnancy scan, was detected to have an orbital tumor, and they were in Bangalore, and then they came for treatment to us. There was a retroorbital cystic lesion, large one, tense orbit, which needed to be intervened. And here again, the answer was to perform a minimally invasive transconjunctival approach. All the tissues were tiny. The child was only 28 days of age. And we had to go through a transconjunctival with a canthotomy, cantholysis, malleable retractors, removing the wall, and then putting everything back with no scar. This is before surgery. This is soon after surgery in the child at 1 year. The child is now 9 years of age and doing very well. Thank you.
I invite Dr. Adityan to talk about radiology of suprasellar lesions.
Dr. Adityan is a neuroradiologist working in Apollo Hospital, and he's a best outgoing student while he's in doing the PG period. He's one of my early residents, gone into do DM in Nimhans, now practicing in Apollo.
This button. Screen next to you. This one. This is next one. Then this slice. Good morning. Today's my topic is about imaging of suprasellar lesions. Dedicated imaging has to be done when suspecting sellar suprasellar mass lesions, like a very thin slice sequence like coronal, sagittal, thin slice 2 or 3 mm sequence has to be done. And the other thing is for suspecting if any small microadenoma, dynamic contrast has to be done. And otherwise, usually we'll do thin slice 0.6 to 1 mm 3D sequences so that it can be reconstructed in any plane. So small lesions and optic nerve and chiasm can be better appreciated. And other advanced imaging like perfusion can also be used. These are the common sellar, suprasellar mass lesions, which can any lesions can occur in the sellar suprasellar regions. Recently, WHO 2021 class has changed the name as pituitary adenoma as PETNET, pituitary neuroendocrine tumors. It can be micro or macro depending upon the size, whether less than 10 mm or more than 10 mm. And another category is the metastatic PETNET. This is a case of Cushing syndrome. We can see the dynamic, very small pituitary microadenoma. We can appreciate in the lateral part of the lesion. And other thin slice imaging also, we can use for appreciating the microadenoma. Coming to macroadenoma, this is one of the is the commonest tumor, which the sellar suprasellar lesion, which is cause compression of the chiasm, nerves, tracts. It can compress. Many times the nerves could not be appreciated separately when the mass is large. We can do dedicated some imaging sequences like dry with contrast so that the nerves like we can appreciate compared to the normal sequences. And the main limiting factor for surgery is the cavernous sinus invasion, which can be whether the cavernous sinus is involved or not. By grading the system, how much the ICA is encased by the mass lesion, we can tell whether it's how much. If it's more than it's grade 4, it is more positive predictably that the cavernous ICA is involved, cavernous sinus is involved. Or we can do this very thin slice sequence. We can see that there is a rent in the cavernous sinus and the lesion is extending into the cavernous sinus. We can appreciate by this. And many times the patient may come with sudden onset of headache, visual defects. In those cases, one of the differential is the pituitary apoplexy. You can see this pituitary macroadenoma with T1 hyperinterest that suggest hemorrhage and layering like this appearance, we can be appreciated. This is a very unusual case we came across. This pituitary, multiple times surgery done in the pituitary with the cella suprasellar region. Many times there is compression of the chiasm. We did multiple times. One time we are able to appreciate the dural lesion and even spinal canal drop mets were there. This biopsy was done. It was proven to be metastatic. The metastatic method is a radiological diagnosis by assessing by histopathological analysis of the distance spread. And similar to any brain tumors, the post-surgery, we usually will do the MRI after surgery within 24 hours so that the residual lesion can be well appreciated. This is a post-surgery. The residual lesion is mainly in the cavernous sinus region. Beyond that, fibrosis changes and all contraction enhancement will occur after 72 hours. So we can't differentiate how much residue tumor is there. For the neurosurgeon, main thing is to assess the tumor stiffness, whether it is soft or odd. Depending upon the various imaging techniques, we can assess whether it's a very odd tumor, very soft. For example, for the T2, where it is very hypertense, it is a soft tumor. Advanced imaging can also be used in various cases of cellular suprasellar lesion. One such is the perfusion imaging, which assesses the tumor blush and whether the tumor will bleed during the surgery can be assessed. And another type of tumor, the term given is posterior pituitary primary tumors by the WHO. This comprises of multiple tumors, pituitary granulocytoma, and oncocytoma. The important thing is that these are these are tumors which shows very intense blush in the suprasellar region. They are very highly. They are one of the most common tumors with a very high chance of bleed during the surgery. And preoperatively, we can diagnose by the imaging technique. We came across recently a few cases, and we proposed a new biomarker for a ASL technique, which intense red ball like this appearance. It suggests the oncocytoma and pituitary. Many of these cases, the cases of preoperative embolization is required. And another new tumor which recently WHO classified is the pituitary blastoma. In young infants less than 3 years, you can appreciate the mass lesion with intense diffusion like embryonal tumor. They can show metastasis. It's a suprasellar, one of the differential diagnosis in meningioma. It is important pre-surgically to differentiate for the neurosurgeons. The one thing is that based upon this, there will be bone changes in the meningioma, and dural tail will and more perfusion will be seen in the meningioma compared to the pituitary adenoma cases. These are this case actually mimic like a meningioma, but it's actually a pituitary adenoma with a low perfusion. This case mimics like adenoma, but it shows very high perfusion. It's proven to be meningioma. And another important differential diagnosis for the suprasellar mass lesions is that opticochiasmatic glioma, amatoma, and germinoma. The glioma can be differentiated by seeing the course of the lesion, where the lesion is along the optic chiasm. It comes along the optic chiasm and the optic nerves you can see. And other thing is that they may not show diffusion resection. The tumor which show diffusion resection is the germinoma which shows intense diffusion resection. And coming to the amatoma, they have same signals as the gray matter in all the sequences. And glioma also, we can differentiate whether it is NF1 or NF2. NF1 usually occurs optic nerves, whereas the non-NF1 occurs the optic chiasm and optic tracts, which is not a strict rule. And the non-NF1 are more enhancing compared to the NF1 tumors. And we also published a recent a new technique like amide proton transfer, which assesses the protein content of the tumor. We propose that glioma are more prone for a high protein content. By using this imaging method, we are highly predictive for the chiasmatic glioma. And very unusual type of tumors can occur in the suprasellar region. This type of opticochiasmatic glioma, whenever we are seeing the bleeding in child with the opticochiasmatic glioma, we must think of FGFR1 mutation. Recently, there was a publication which shows this type of mutated tumors. And other type of tumors and non-germinative tumors can occur in this location. They are more prone for hemorrhages compared to the other tumors. Some unusual tumors also we are reported, like cavernoma can occur in the hypothalamus. This case, the preoperatively there is a significant field defect. After the postoperative, the field defect has significantly improved. These are all cases proven to be cavernoma, which can cause compression of the optic chiasm. The cystic lesions and the commonest cystic lesions, two differentials are craniopharyngioma and rachiclosis. We can differentiate preoperatively between these two. Craniopharyngioma usually show wall enhancement will be there, whereas the rachiclosis should not show wall enhancement. Craniopharyngioма shows more septation, cystic calcifications. By that, we can differentiate. And we also see the craniopharyngioma when after surgery, they are more prone for recurrence. Usually we give radiotherapy, and we also propose the changes in the intensity of the cyst. And after proton therapy, the cystic changes are prone for reduction, and the protein content gradually reduces. And one the difference is the pituitary stalk lesions. Pituitary stalk lesions, the stalk will be thickened more than 3 mm. And one differential is Langerhans histiocytosis. They can show bone lesions. And other differential diagnoses like granulomatous, lymphocytic hypocytes, and many differential diagnoses are there. One congenital condition which should not be taken as a mass lesion. This is a persistent embryonic infundibular recess. The infundibulum may go down and mimic like cyst. This was initially referred as some cystic mass lesion, but we told it is a persistent embryonic infundibular recess. And other differential diagnoses are epidermoid cyst can occur. They show intense diffusion resection. So preoperative MRI, down is the postoperative, the epidermoid cyst is completely removed. And other differential diagnosis which came across, the ruptured dermoid cyst can occur, like this suprasellar lesion with optic nerve chiasm compression. Other thing is some embryological abnormality like craniopharyngeal canal. Sometimes the mass lesion, like many mass lesions, can occur in the cella. This is actually a case mistaken as pituitary adenoma, but finally it was a medulloblastoma, which was mimic mets, and it was proven to be medulloblastoma metastasis. And other sometimes bone tumors can extend into the suprasellar region with compression of the optic chiasm, optic pathway. So some other differential diagnoses like chordoma, GCT, giant cell tumors, and ABC. Preoperatively, we can differentiate each of these conditions by various imaging techniques. And advanced imaging like DTA can be used so that the optic nerves and fibers can be visualized so that the appropriate site of biopsy can be done. Some advanced imaging like resting state fMRI, like new imaging techniques, so that we applied for the hypothalamic hamartomas, so that the particular site for RF ablation can be done. These are some of the commonest tumors of the suprasellar region. Many of these tumors can be preoperatively accurately diagnosed by the imaging. It will be helpful for the surgeons. Thank you.
May I invite Professor Suresh Babu to talk on management of suprasellar lesions.
At the outset, I thank Dr. Rupesh and Vijay Sundar for inviting me to this. So, yeah. Nice. Team can avoid this. No? They put him in. Yeah. Okay. Thank you. You saw Dr. Adityan giving a whole list of pituitary tumors. Of course, the pituitary adenomas, functioning and non-functioning adenomas are the commonest tumors which we come across in practice. But we should also remember that pituitary hyperplasia, hypophysitis, granulomatous diseases, and so many other conditions which Dr. Adityan showed, they may look like suprasellar tumors, and but we may have to avoid surgery in some of them. Say how pituitary tumors are they're cellular tumors with suprasellar extensions. They are not primarily suprasellar tumors themselves. Why it happens now? Sometimes now you find that the cellular component is very small, but suprasellar component is huge. That can happen supposing the diaphragm macula is very defective, then the tumor just grows in the path of least resistance and doesn't try to remodel the cellular bone, but it grows upwards and can cause like this. Of course, you may get pure suprasellar tumor without cellular component, which we have seen. For example, this patient, we thought it's a meningioma. We did a transcranial approach, but the biopsy report was a null cell adenoma, and we can call it as a ectopic pituitary adenoma. This probably is the only case which we saw in the past so many decades. So, of course, we did a transcranial excision of that tumor, and we found it was a null cell adenoma. Of course, for suprasellar tumors of pituitary origin, the management options are where observation, medical management. We can do surgical excision, transnasal, transcranial, and radiotherapy. These are the different management options. Yeah. Hmm. Yeah. These are the different treatment options. And, the surgical approaches, it is mostly now a transsphenoidal endoscopic endonasal approach. We are earlier doing microsurgical excision. Now we do extended approaches, transtubercular, transcavernous, transpterygoid, transorbital approaches. And the transcranial can be pterional, subfrontal, supraorbital. All these things can be combined in some of these patients. Now, if you see my experience myself, I did my first transsphenoidal microsurgery in 1984 after visiting Yasser Gill, and Landolt was his colleague. And after seeing that, I started doing and then we started using endoscope in a limited way in 2006 when we used endoscope in addition to microscope just to see how it looks around the corners. But later in 2012, there was a paradigm shift from microscope to the endoscope because of the influence of the ENT surgeons. We learned from ENT surgeons the technique of using endoscope endonasally, and then we did a good number of patients. We keep doing that. Of course, we added extended approaches. We use navigation. We use microvascular Doppler, VEP. All these things we keep doing. But in 2012, we found that in spite of all these things, still we are having sometimes some bad outcomes, some errors happen. So we started using institutional checklists and protocols for endoscopic pituitary surgery. This is to avoid human error and to minimize complications. We have a lot of checklists. There are almost 12 to 13 items, and each one has got an anecdote and a clinical experience. Based on that, we formed this checklist. For example, a patient with hyperplasia, we have to just make sure that thyroid has been done. It's not primary hypothyroidism. Just make sure the patient is not on IVF treatment. Those things are there. And just tell one example of, we as neurosurgeons, sometimes we don't even see the radiologist report. we just see the images and keep posting the case and doing that. So this patient, I'll tell, see, the patient came with a tumor like this, with visual problem. I saw this, and then I said a patient needs surgery, endoscopic and endonasal surgery we will do. Then my physician assistant who read the report, she doesn't know how to read the MRI, but she knows how to read the radiologist report. And she told me, sir, there is an aneurysm, they reported. Then I looked back and then found that there is an aneurysm which has been mentioned by the radiologist. So it was a very important thing because it's game changing. If you had not operated that patient without coiling, probably the patient might have died of some intraoperative bleeding. So it is very important. So like that, no, or any near miss, any error, any adverse event that happens, then we do root cause analysis and we update the institutional checklist. That's how we have formed this checklist in our practice. So the idea is now we have to develop a culture of safety to our patients. So and no, there is always room for improvement. If you can achieve a 95% good outcome, then you can always go a bit more and try to achieve 98% or 99% because we know still we have many lacuna in today's management. So we know prolactinomas can be treated by cabergoline, but still some 10% of the patients, they don't respond and they come with hemorrhage. So how do you detect that? Now, probably A is now, if you see the literature now, the MRI texture is of a prediction of non-responding prolactinomas can be being developed. So also in acromegaly, we know it's a prediction of the endocrine cure is very difficult, and AA-based radiomics are all coming to predict postoperative growth hormone nadir group in which you can get an endocrine cure, and you can select these patients by radium. Still, we are far from this because as of now, the artificial intelligence which is available for doctors has got many limitations. And it is something like this. When we started microsurgery, we had a microscope like this size OPMI, and we struggled so much to use this. Now we have something, Pentro or Kineva and Mitaka, in which it makes the use of microscope so useful. The same way, I am sure in the next 4 or 5 years, the AI technology also will improve soon, and we have to start using that. Doctors not using AI may end up getting replaced by doctors who are using AI. So this we have to remember, and all of us should start using that. For example, now you have this patient, you have a pitnet with metastasizing tumor. So this patient came to me in 2006. I operated. It was a beautiful surgery. Postoperatively, he is doing well. Now in 2015, he came with a dural-based tumor on the tent. We operated that. Next year, he came with another tumor in the CV junction. We operated on that. We gave radiotherapy. Ultimately, he died of radiation changes, and we lost him. So we are far from the perfect. In some of these patients, very difficult to treat these patients. I can tell a lot of scenarios, but I think there are so many small case scenarios I have, but I think I'll skip all these things because there's lack of time. So post-operatively, we have to check the visual status. Some of these patients, they deteriorate due to some hematoma. Then we have to re-explore immediately and operate on these patients. We have to treat these patients with empathy and compassion. And post-op neuro-ophthalmic review is very important. We have to document the visual acuity fields. Sometimes now we have the chiasmal diplopia. It's not at all uncommon. We may have to advise the prism glasses or some exercises to do that. Endocrine management follow-up is all very important in this management of these patients to decide on radiotherapy or revision surgery. So I tell the patients surgery is the beginning of the treatment, not the end of the treatment. So to conclude, I'll say, Katrathu Kaiman Alavu, Kalladadu Ulaga Alavu. And to add, no, Sonnadu Kaiman Alavu, Solladadu, at least lot of, lot of development. That's how I will end my talk. Thank you very much.
The next talk is from Dr. Rupesh Kumar on the management of suprasellar lesions. Suresh, the histopathology is multiple tumor site operator. Histopathology.
I think I'm holding you all for lunch. So sir has covered most of the pituitary, which is the most common tumor. But however, we learned from Dr. Aditya that there are a lot more tumors in the suprasellar region. And so I will cover non-pituitary tumors, which like common being cranios, meningioma, and other rarer ones like chordomas. I'll just go through glance of each tumor. What is the principle and treatment? So this is the view, endoscopic view. As we see here, so we see that the pituitary gland is extradural. It is below the diaphragma sella and the pituitary stalk. Then this is the optic nerve, the chiasm. So you can see how close it is, so that the tumor, if it grows, it can compress the optic nerve and chiasm. And you never see a pituitary with a pituitary insufficiency. However, the other tumors, the craniopharyngiomas, the sister of pituitary, they always, most of the time, present with endocrinopathy because of the pituitary stalk involvement. So the strategic difference between the pituitary surgery and non-pituitary, pituitary is primarily extradural. So very rarely we enter into the dural compartment, whereas the other tumors, most of the time we have to enter into the dura, and so that is a fundamental difference between the pituitary and non-pituitary. Most of these tumors, which Suresh Babu was telling that we were doing microscopically, but even now the non-pituitary also now the paradigm shift of doing these tumors with the help of an ENT colleagues to do endonasal endonasic approach. Even patients demand that they also don't want a craniotomy, they wanted to do a minimally invasive through the scope. So the common tumor being the craniopharyngioma. So most of the time now craniopharyngiomas are being removed endoscopically, and especially the ones, the retrochiasmatic, which is the commonest, and tumor descending down into the sella and small midline tumors. So you can see typically, as with the craniopharyngiomas, this is the chiasm. So this is behind the pituitary chiasm, and most of the time they present with, it descends down into the sella, pituitary is pushed down. So this is the surgical strategy which we follow. And we can see that this is the endoscopy. This is how we see. This is a fast forwarded view. So you can see this is the pituitary down here, and then the pituitary stalk. So we have to work on either side of the pituitary stalk, and keeping in mind, we can see this is the pituitary, flattened pituitary down, the pituitary stalk nicely seen well. So between the two corridors of the pituitary stalk, we try to remove this tumor. Unlike pituitary tumors, which are soft generally, craniopharyngiomas are a little harder, sometimes fibrotic, so we need to be careful. Most of the time they calcified, and we can see there's the big calcified chunk. Initially we were apprehensive of removing through the nasal approach, but then now with the expertise we have gained confidence in removing difficult tumors like this to the nose, and we can achieve a good excision. So we can see that this tumor being removed, and the best advantage of this is that these are totally blind by microscopy. So you can see this beautiful approach, the complete view of the third ventricle, the foramen of Monro, the aqueduct. This is almost impossible to achieve by microscope, whereas with endoscope now we can with ease, so that the radical excision is much better with these endonasal endoscopic approach. And most of the time we avoid radiation. These are young children. You can see that the complete excision, we just do follow-up imaging every year, and if there's a recurrence, then we consider radiation therapy. So craniopharyngiomas, we can see some cases we do transcranial approach, especially the ones which are lateral. As you see here, this tumor comes lateral to the carotid artery. Whenever the tumor is lateral to carotid artery, we do prefer a transcranial approach, and we can see how the difference. You can see whatever we do in an endonasal endoscopic, we do not handle the optic nerve, because the optic nerve is the last to see, whereas in a microscopic approach, invariably we try to work around the optic nerve. So that is the difference. So most of the studies literature quote that the visual outcomes are better with endonasal endoscopic approach rather than the transcranial approaches. We can see, however careful we are, we can see that is the optic nerve, and this is not working. So that is the optic nerve, and we are working between the optic nerve and the carotid artery. So whatever we do, however careful we are, we can see that we are handling subconsciously without suction, we can see however careful we are. So whereas in an endoscopic approach, we are totally away. So you can see this is very important. So we try to preserve not just the tumor, most important is these small hair-like perforators which supply the undersurface of the chiasm, which supply the pituitary stalk. So most of the time the visual decline may not be directly related to your optic nerve handling, but damage to these fine perforators which come the superior hypophyseal artery branches, which typically supplies the undersurface of chiasm. So ischemic complication, that's where the patient can deteriorate potentially. So we need to be extremely careful in our surgical approach in removing this tumor. We can see that this tumor has been completely removed using this approach. Now the next common tumor is meningioma. And meningioma, most of the time we do transcranial, but there are select cases which we do endonasal endoscopic. As you see here, this is a very small tumor, but patient presented early because of the visual field. You can see direct compression of the optic nerve. This is a fast-forwarded video, again endonasal endoscopic approach, and we can see that this tumor being delivered wholesome, and we can try to preserve the arachnoid because all the vessels are inside the arachnoid. So if you are able to carefully preserve the arachnoid, you are able to preserve. We can see that the tumor has been gently delivered, and these patients have a wonderful outcome because this is a direct pressure of the optic nerve. So however bad, we'll be able to reverse the visual defects in these patients. And we can see we are never handling the optic nerve. The optic nerve is at the last, and we are tumor directly only into the tumor, drive the tumor into the nasal cavity. And we can see here the optic nerve is visual last. So that is the optic nerve on the right side, the optic chiasm. That is the ipsilateral optic nerve. And why does it is attached now? This is the internal carotid artery. So we have to be very careful. So the chances of vascular injury, internal carotid is high in non-pituitary tumors, because you can see here, so that attachment sometimes can be very firm. If we miss it, then we can have torrential bleeding, the internal carotid artery injury, as you see here. So once the tumor is removed, we can see now that this tumor was attached to the internal carotid artery, and we will see here how the internal carotid artery and the ophthalmic artery. We can see that is the internal carotid, that is the ophthalmic artery which is going into the orbit. The main attachment of the tumor was the dura very close to the internal carotid, so that you have to be very, very careful. And we can see that the post-op, a good visual outcome in these patients. But so some patients, we do endoscope, transnasal or a transcranial approach, and we see the fundamental difference, how much we are able to handle the optic nerve, because effectively we can see this is the optic nerve. We are working in between the two optic nerves in tuberculosis meningioma, and that is the difference we can see. However careful we are, we can see that the micro movements of the optic nerve. So already compromised vision, we have no choice but have to subconsciously, though we work on the tumor, there will be some micro movement. This is a fast forwarded video, but that's why you are appreciating the movement. So we have to be extremely careful, and we can see the tumor behind the optic nerve is blind. So we have to deliver the tumor into the compartments. So there is a fundamental difference. That's why paradigm shift now, we are doing more and more these cases transnasal endoscopic approach, because of the very good visual outcome after this patient. But still we can see that we were doing this, and we can see that post-op we are able to trim it. But large tumors like this, we generally do transcranial approach when we avoid endonasal endoscopic approach. And we can see all the perforators. So that is more important. The perforating vessels have to be preserved to have a very good visual outcome in these patients. And we can see that there's a good visual outcome improvement in these patients. Chordomas, again, I was fortunate to work in Apollo Proton, where with the chordomas, we have never seen chordomas before so commonly, but because of the referral center, we could operate and get a good experience, and we had operated a lot of chordomas. Chordomas are completely different ball game. Unlike pituitaries or craniopharyngiomas, they are very hard. I'm not going to go through the video because of the want of time, but then most of the time they are recurrent, they are redo, so we have to use image guidance in these cases. And again, to deliver the proton therapy, we have to clear these tumors from the optic nerve. That is very important. That is why we still consider we can decompress the optic nerve, so that the high lethal dose of radiation, like 75 gray, cannot be given if there is a residual tumor close to the optic nerve. That is why radiation oncologists insist us to remove these tumors from the optic nerve, so that they can go for a high dose of a radiation therapy. Rat case clubs is not very common, but then we can see typically they do present with optic nerve compression, the chiasm. We can see that there's a small cyst presenting, and this patient, I can do a transnasal endoscopic approach. And again, I didn't have a pre-op, but the post-op, we can see that the very good visual outcome. The optic nerve compression has been relieved, but the chance of recurrence is high. We need to be very careful if we don't marsupialize the cyst. This looks like a craniopharyngioma, but actually they are pilocytic. Dr. Adi showed this case. So this is a child, a lot of dilemma whether to operate, to give chemotherapy. However, with a good surgical expertise, we can do surgery in these patients. I'll skip this video, but we can see that the post-op, though it is an optochiasmatic glioma, we could achieve a good decompression with a good preserved visual outcome. Very important, Adi showed in one of his slide, and we initially thought it is a craniopharyngioma, but actually it turned out to be a germinoma. So germinomas, especially, you have to be, we have high index of suspicion, and sometimes we may not be able to do preoperatively, and we can see that. So post-op patients need radiation. Again, a great mimicker, same case, germinoma, we initially mistook as meningioma, excised it, and then came out as germinoma. The treatment of germinoma is chemotherapy and then radiation therapy. This we all know that, again, a great mimicker, treated as optic neuritis, and patient lost vision ultimately, and then we can see that the thickening of optic nerves, we did a biopsy because patient was continuing to worsen and again turned to be germinoma. So germinoma can be a great mimicker. It can mistake masquerade as a meningioma, as a cranio, or as an optic neuritis. So we have to be very careful. I think only the pathological examination is important. And immature teratomas, again, non-germinomatous germ cell tumors, they are also common, not very common. And however, we try to leave behind a thin rim of tumor into the floor of third ventricle, where there is the hypothalamic centers for the endocrine function. So these young children should not develop endocrinopathy. So that is why we are careful enough to preserve a layer of tumor. Again, very interesting case. Thought as of a lymphocytic hypophysitis, patient was treated on steroids. You can see that the infundibular stalk thickening, that is one of the hallmarks of fasciitis. Patient continued to have vision loss, large cystic lesion, went in transnasally in another center. There was some pus-like material, started on IV antibiotics, started as a pituitary abscess, secondary to a long dose of steroids, and then is a diabetic, continued to lose vision, and then almost a glimpse of loss vision on bilaterally. A few vision was there on the right side, and then this patient came to us, and then we did a transcranial approach, and then finally turned out to be metastatic adenocarcinoma. The mucin secreting material was mistaken as an abscess, and then finally this patient went on to get radiation therapy. So we have to be very, very careful in evaluating and treating these patients. We should not miss the diagnosis in these cases. Again, the last slide, Sir showed one case of an aneurysm. We should not miss out. This patient actually was referred as a tuberculosis meningioma. Whenever you see a two rounder lesion and with a filling defect, we shouldn't. This is totally a giant aneurysm of the anterior communicating artery. If you mistake and go inside, you will land up in trouble. So you can see a giant aneurysm, and then these patients require a surgical clipping. They're totally different ballgame. Again, this is a very recent case referred to us as a pituitary adenoma versus tuberculosis meningioma. Again, too well defined, and we can see that whenever we see a flow void, I think we should be very careful, do an angiogram, and then this is again a giant aneurysm of the superior hypophyseal artery, and then we had to clip it aneurysm. So suprasellar lesion, diverse pathologies can happen. Of course, pituitaries are the most common, but we equally have cranios, meningiomas. Each has a different surgical strategy, chordomas, Rathke's clefts. So everything has different, and the ultimate goal is most of these patients come for visual. They come to the ophthalmologist for visual problem. So our goal is to decompress the optic nerve and chiasm so that the vision outcome is much better. So thank you very much.
Thank you, sir. The session is open for discussion. Any doubts, queries about this whole session? As we are setting things up for a group photo, we can have a discussion.